Good afternoon, everyone. My name is Khushbu, and on behalf of Voice of Healthcare at the outset, allow me to welcome all my guests and audience who have joined in for this summit. VOH is delighted to present and welcome you all to the Universal Health Summit, which is a virtual initiative to recognize Universal Health Coverage Day. We are highly thankful to our partners who have come forward and helped us organize the summit and help us bring together this stellar list of speakers and panelists for us. This event and this discussion is supported by UN Global Compact Network India. Our other supporting partners are Invest India, Apollo Hospitals, Yashoda Super Speciality Hospitals, Parul Sevashram Hospital, Association of Healthcare Providers of India, and Association of Indian Medical Devices Industry EMIT. Thank you to all our partners. To mark the beginning of this discussion, I'd now like to bring forward to you Dr. Somnath Singh, who is the program manager. I'm so sorry, there was an echo. I'll start again. So, to mark the beginning of this discussion, I'd now like to invite Dr. Somnath Singh. He is the Program Manager and Lead, Center of Excellence for Governance, Ethics and Transparency at UN Global Compact Network India. Dr. Singh is an academic practitioner with over 22 years of demonstrative experience, working with different sectors including government, corporate, CSOs, academia, and UN system. Gaining his master's degree in social work and management team from Delhi University. In December 2020, he was also awarded with a doctorate degree in management by OPGS University, India. Without taking any further time for this discussion, I'd like to now hand it over to Dr. Somnath to take forward this discussion from here onwards. Thank you so much. Dr. Somnath, you're on mute. If you could unmute yourselves.
Sorry for the disturbance. Thank you, Dr. Khushbu, for introducing myself. And to the beginning, it's a wonderful day today for all the healthcare organization. So I will not take much time. On behalf of UN Global Compact Network India and Voice of Healthcare, I warmly, welcome our global leaders, Ms. 𝗙𝗖𝗥𝗘𝗔𝗧𝗑, Chief Intergovernmental Relation and Africa at UNGC New York, all the eminent speaker managing different healthcare programs, working with different healthcare organizations and sectors. We are so grateful for your precious time and presence at our Universal Health Coverage Summit 22. And I'm sure we will be enlightened with the knowledge and the great thoughts of the expert speaker and, of course, audience participations. In the last of my address, I would like to say that UN Global Compact Network India is a country-level largest corporate sustainability platform that functions to implement SDG and UN 10 principles in the areas of human rights, labor standard, environment, and anti-corruption since 2000. With an active engagement of over 500 members from corporate, academia, PSU, CSO, etc., we are successfully implementing the SDG UN 10 principle, including other sister initiatives of UN Global Compact. Currently, with support from UNGC and under Siemens Integrity Initiative, UN Global Compact Network India is implementing the project called Scaling Up and Advancing Anti-Corruption Collective Action within the Global Compact local networks and trying to promoting transparency and value-based healthcare in healthcare sector in India and advancing anti-corruption collective action practices in MSME sectors. Not taking of much your time, now I would like to invite Mrs. 𝗙𝗖𝗥𝗘𝗔𝗧𝗑. She is an experienced head with a demonstrated history of working in the international affairs industries, skilled in international relations, corporate social responsibility, anti-corruption, diplomacy, and international development. Strong professional, graduated from University of Lagos. We welcome you, ma'am, to our Universal Health Coverage Summit 22. And thank you very much for accepting our invite to grace the program event with your valuable presence. Also, I would like to request you, ma'am, during your keynote address, please share an overview of anti-corruption collective action and your experience in anti-corruption project with a focus on healthcare corruption. Thank you. Thank you, ma'am, once again. Now over to you.
Thank you very much indeed, Somnath, and thank you very much indeed for inviting the UN Global Compact New York, We thank our colleagues in India and all the partners for organizing this day. Indeed, today, December 12th of 2022, marks, as in every other year, the Universal Health Coverage Day. It is the day on which we call on leaders here in India and around the world to make smarter investments and accelerate efforts towards health for all. Health for all, I emphasize that, in the world we want. A world in which everyone, everywhere, has access to quality health care, wherever they need it, whenever they need it, and without suffering financial hardship. Universal Health Coverage Day provides the opportunity to celebrate progress and to raise awareness about what is required to deliver essential health care for families and communities everywhere, no matter their status in life. UHC is capable of lifting people out of poverty, promoting the well-being of families and communities, protecting against public health crisis, and moving us towards health for all. This year's theme, Build the World We Want, a healthy future for all, emphasizes that in order to build strong health systems, we need equity, we need trust, we need healthy environments, we need equality, we need investment, and we need accountability. We must recall that the Sustainable Development Goal 3 addresses good health and well-being with the objective of ensuring healthy lives and promoting well-being for people of all ages. SDG Target 3.8 is concerned with UHC. Universal health coverage addresses the questions: what do people need to get? What do people need to be and stay healthy? Can they get help from a well-trained health worker? Can they get treatment that helps them get better? Can they get the medicines and other health products that they need? And who will pay for it? It also asks, are there policies in place to ensure that the needed services are available when needed? Does government have accurate information about the healthcare system to provide the right policies and to ensure their implementation and financing, even in times of crisis? And then also, how do we ensure a health system that does not merely treat sick people, but that helps to promote healthy living and to prevent people from falling ill in the first place? For this to be true, we need a healthcare system that focuses on the health outcomes of patients and the value or quality of services rendered, rather than one that simply rewards health service providers based on the volume of services or procedures delivered. A value-based model is one that promotes universal health care through providing holistic, high-quality, and efficient patient care. It is to be preferred to one that simply focuses on the number of healthcare services or procedures delivered without considering the actual impact achieved. Universal healthcare can only be meaningfully achieved in a healthcare system that takes the challenge of corruption seriously. In the healthcare sector, decisions are often matters of life and death, and the human impact of corruption can be dire and life-threatening. This is regardless of whether corruption concerns graft or malpractice in the provision of health services, misappropriation of health care funds, supply and prescription of fake or outdated medicines, or the falsification of professional qualifications. Wherever it exists, corruption in the healthcare system goes against the grain of the no one left behind philosophy, which is the foundation of the SDGs and our work at the UN Global Compact. The SDGs are a call to action by all countries to promote good health and prosperity while protecting the planet. Through the SDGs, we are inspired to work towards a healthier, better, more equitable, just, and prosperous world. Hence, the SDGs represent our collective roadmap and a guide to a place where no one will be left behind. I acknowledge the prime responsibility of governments as sovereign entities to address corruption within their national domains, which includes the healthcare sector. This notwithstanding, private healthcare service providers must realize that their response to corruption must not remain passive, reactive, or compliance-based. Rather, their approach to corruption must become active, They must proactively tackle the challenge posed by corruption within the healthcare system and be ready to propose bold, innovative responses. Collective action is one of such responses. Multi-stakeholder partnerships are needed to tackle corruption within the healthcare sector, as in all other sectors. Such partnerships should be inspired by SDG Target 16.5 to substantially reduce corruption and bribery in all their forms, and the UN Global Compact's 10 principle, which calls on businesses to work against corruption in all its forms, including extortion and bribery. SDG Target 1717 also calls for encouraging and promoting effective public, private, and civil society partnerships, of which collective action partnerships against corruption are a relevant example. Through coordinating their efforts and acting collectively, healthcare service providers will be more effective at preventing the practice of corruption and at mitigating corruption-related risks. The UN Global Compact has been implementing collective action against corruption for over 10 years with our colleagues at the local network India. And recently, we developed a playbook on anti-corruption collective action. I strongly recommend this as a reference. There are many other resources on our website that you can avail yourselves of. In closing, I must affirm that to achieve universal health coverage in India or globally, it is imperative that we deal with the malignant cancer of corruption, particularly in the healthcare sector, which is regarded as one of the most corrupt in the world. North or south, east or west, in developed as well as in developing states, corruption remains a cancer and a scourge, one that we must all act consciously, collectively, and with determination to address, and concerning which all healthcare service workers, whether from the private or public sectors, must be prepared to play an active role. We are ready at the UN Global Compact in New York and at our local network in India to work with all partners for the collective action against corruption in the healthcare sector. I thank you for inviting me. Thank you, and have a wonderful Universal Healthcare Day where no one will be left behind. Thank you. You are muted. Can you unmute yourself, please?
Yeah. Sorry. Thank you. Thank you very much, ma'am, for your wonderful and insightful views and guidance to address corruption challenges across the healthcare sectors. Thank you very much for your great keynote address. Now I hand over the floor to Dr. Čibar, who is going to moderate the panel discussion today with his eminent speaker. Would like to speak a few lines about Dr. Rajiv Čibar. He is a Vice President, External Affairs, Sahajanand Medical Technology Limited, and Joint Coordinator, Government and Public Affairs, IMED. Dr. Rajiv Čibar is a Senior Corporate Affairs Policy Communication and Media Strategist with experience across pharmaceuticals, medical device industry, healthcare, environment, power, and the development sectors. He is a member of various government committees, subcommittees in the areas of public health advocacy, pharma and medical devices, nutrition, tobacco control, NCD, and climate change, in addition to being on various industry committees of CII, IMED, FICCI, ASSOCHAM, PSD Chamber of Commerce, and American Chamber of Commerce. Also, he is associated with various national and global organizations, putting his proper efforts to strengthen healthcare sectors with ethical practice in India. Thank you very much, and over to you, Dr. Rajiv Čibar.
Thank you very much. Thank you, Dr. Somnath. And I would like to really thank the earlier speaker, ma'am. She, in fact, it was 3 a.m. in New York when she gave her keynote address, and we're really indebted to her in terms of her commitment towards this particular day, the Universal Health Coverage Day. So welcome all. Welcome to this session today, and this session by VOH as well as the UN Global Compact is a very power-packed session today on universal health coverage. This is, as ma'am said earlier, a UN International Day that ensures all people everywhere can get quality health services they need without financial hardships. So every year we do celebrate, and since 2013 onwards, December 12th as Universal Health Coverage Day, which is a very strong call for equitable health systems that will leave no one behind. And today in this series, the theme that has been given to us is a very peculiar and a unique theme, because not only post COVID, the entire world is looking towards a sustainable healthcare future, but also India as a country is also looking towards a sustainable healthcare future. And the panel discussion which we have today is themed promoting volume based to value based healthcare to ensure universal health coverage with collective action. Now, ladies and gentlemen, you would have heard our Honorable Prime Minister Narendra Modi ji from the Red Fort this year on the Independence Day, when he talked about India being a contributor to the entire healthcare, fraternity globally. He gave a clarion call that from healthcare, which is generic healthcare, we should be moving towards quality healthcare, which quote unquote in his words said Jai Anusandhan, which means well researched R&D that will be now the fulcrum of quality healthcare that we will be looking at. So today I am having the best panel, a power packed panel today, which would be deliberating on how universal healthcare is going to really talk about the theme that we envisage, and also the United Nations global theme, which is ensuring strong and equitable healthcare systems that leaves no one behind. So with me, I today have Dr. Rajesh Chitre. Dr. Rajesh Chitre has been associated with the pharmaceutical industry for over 3 decades and has worked at various positions. He's completed his PhD in corporate governance in pharmaceutical industry, and during his studies, he did interact with many eminent, which included the President of India, industrialists, renowned academicians. He is currently working as a sub-regional compliance officer for Merck and supporting for pharma, chemical, electronics, and IT sector of organizations. So welcome, sir, to this panel. I again have another very powerful panelist, Dr. Ratna Devi. Welcome, ma'am, to the panel. Dr. Ratna Devi is a medical doctor, a public health, and a management professional. Dr. Ratna Devi brings more than 30 years of experience working to improve health outcomes in India, and she spent her initial 10 years in the government, and for the past 20 years, she's been working with national and international NGOs for public health initiatives. She's got a demonstrative experience in managing large-scale programs for success and scaling up innovative pilot program across India at national as well as state level. Presently, she's also leads this cross-disease patient alliance in India called Indian Alliance of Patient Groups, which is IAPG, and is the immediate past chair board of the IAPO, which is the International Alliance of Patient Organizations. Welcome, ma'am. Welcome to this session. I also have the privilege of... Sorry, I think there's an echo somewhere. I also have the privilege of Dr. Mahesh PA. He's a professor pulmonary medicine with JSS-MC, and presently his special areas of interest are in asthma, COPD, air pollution, food allergy, and drug allergy. He's been given very special awards and recognitions as a young scientist at ICAAI, Raju Award, ICAAI, WAO travel grant, the best thematic paper that has been presented by him. He's serving on 9 committees of the American Academy of Allergy, Asthma, and Immunology in the US. He's served on difficult asthma and climate change and allergy working groups at the AAAI, Foundation for Allergen Immunotherapy course, and pollen food syndrome there. And he's being very well funded and guided by ICMR, the Europe Commission, the DST, UGC, FIP, DBT, the Indo-US NIH grants. So in a nutshell, we've got someone who's got an experience with key diseases that are looking at humanity because of climate change. I also have with me Professor Joshi. Professor Joshi is a visiting faculty at the Somania Management and BITSOM social projects. She's a member ACCA committee at the United Nations Global Framework also. She's a trustee of CEGET, an NGO for tribal women from Gujarat since 2015, and a member on the advisory board of Shiksha Sambal program, Hindustan Zinc Limited, Tesser India, National Artisans Development, and Ratna Nidhi Trust in Mumbai. She's also a member management committee of the Walia College and Board of Studies at Khandabla College. Welcome, ma'am. Welcome to this session itself. So, ladies and gentlemen, we started our session with a very wonderful keynote address that talked about how United Nations is really looking towards a universal access towards quality healthcare services. And it would be, amiss if I do not allude to the COVID pandemic, because the COVID pandemic has again showed that universal health coverage and health security are intertwined goals to protect everyone, and that is what we would want to achieve. That is what every government would want to achieve from the same health systems, that gives them not only access, equitable access, but coverage, and also puts the vulnerable first, because they are the ones that are the most significant barriers of this essential healthcare program. So, in a nutshell, I would say we today at this particular day are not only celebrating but also deliberating on the fact that how are we going to now move forward this particular uh, pandemic ahead. It is already 3 years in the pandemic, and how this pandemic will now assure that we as a country will be able to promote from a volume base, the one that we were known as generics, to a value based healthcare system, and that to a collective action which reaches the poorest of the poor. So let me first come to Dr. Rajesh. Dr. Rajesh, you've been at Merck, and you've also, looked at the entire pharmaceutical industry from a very close angle, being in the industry itself. How would you define the role of the pharmaceutical industry towards an equitable, accessible, and affordable healthcare context? I think you'll
Thanks,
have to.
Doctor. Yeah.
Yeah.
So thank you very much for this question. And pharmaceutical industry is an important cog in entire healthcare system. The recent example is in the pandemic, that everything was closed except that the healthcare sector had been continuously working 24/7. And when everything was closed, all shops were closed, all these medicinal stores were operating throughout day and night for that. So it played very important role in this entire healthcare system. Coming to that, you have asked about accessibility and affordability from the pharmaceutical industry. Accessibility is concerned, that is, we have reached far more miles in the accessibility, and not only we are self-reliant, but we are also exporting to a number of countries across the globe for that. Again, the example of pandemic, where that is we supported to 100 plus countries for all this vaccination, antibiotics, and other medicines which were required for this to tackle COVID-19 situation for that. So it's a really great achievement for that. Secondly, about again accessibility and reachability to common people. Again, the vaccination, if you take it, that is we are self-reliant, and we also supplied. We use various tools, digitalized tool, and we ensured that is all should get this vaccine in India, and all this record is available at the fingertips of in our laptop or any site for that. So I think it's a great achievement. Again, in the accessibility, that is the supply chain plays very important role into that. And there also, in the last 15 to 16 years, we have achieved a great miles to achieve these goals for that. Coming to the second part, that is how pharmaceutical industry is tackling this affordability issue. So yes, that is this is a debatable issue, but simultaneously the drugs are available, medicines are available at the cheapest cost in comparison with the global standard. That is one observation. Second is that we have a wide range of medicines are available in India, and that is like including that the generic medicine. So the patients now can choose that is which medicines he or she wants to take for that. And again, another example is of the TNMNC, that is the Tamil Nadu Medical Service Corporation. So it ensured that, as my previous speaker also informed about it, that is the quality also plays important role, not only the pricing. So that is that TNMNC has also ensured that in last 25 years, that is, it is giving affordable medicines, purchasing affordable medicine, giving it to the government employees and also to the common people, and also that is the its quality is well maintained for that. So these are some good examples are there of this access and affordability.
Yeah, absolutely, absolutely. So you addressed accessibility, affordability, and availability.
Mhm.
Obviously, is something which we're looking at. So I'll play a slight devil's
Yeah.
advocate here. I'll actually, why I chose the industry to speak first was to get a sense of how the industry is actually working on addressing these three A's. I'll actually now shift immediate gears to Dr. Ratna Devi, ma'am. Ma'am, if you could unmute yourself. You've been, and I've seen you also. I mean, I've in my earlier roles worked with you also at MSD Workshop and Boom, where we kind of like created the entire HPV vaccination for girl child and other areas. But then, playing a devil's advocate, as I said, when the industry talks about ensuring an equitable healthcare system where no one is left behind, we still find the marginalized and vulnerable populations, and those populations which are actually gaining into these rare diseases and the kind of NCDs that are catching up, not getting that kind of an access. But if there is an access, that access is at a real time cost. How would you address the entire spiel of our today's theme, which is promoting value-based healthcare to the marginalized?
Thank you, Dr. Chibur, for that question. And it's kind of hard to answer it in just the 2 minutes that I have. But,
I understand.
the volume-based healthcare and value-based healthcare are sort of words that you and me understand. Patients on the street who need the services just want those services in the safest of environments and with the highest of quality. Unfortunately, healthcare is driven by the supply side. So patients with their lived experience or communities and families are never asked what they want or how they want it or where they want it. It is sort of given to them as a package, either from the private sector or from the government, and they are left with no option but to take what is served to them. So talking about value-based healthcare makes no sense until we involve the patient in the design and the production stage of whatever packages are being made as part of the universal health coverage program. So just to answer your question about, how do we see that the industry saying that everything was made available, and was it really available, and did people benefit from it? I think the pandemic taught us a very important lesson that the rich or the poor, or the better healthcare systems and the stronger and the weaker ones, everything collapsed. What remained was families and communities helping each other and sourcing those medicines for people who needed them. The supply chains had completely collapsed. The medicines were not available in the market, or if they were available, they were at very steep prices, and we knew that there were no controls that were working at that point of time. And this tells us that while we talk a lot about involvement of communities and patients, it really doesn't happen, because if they were involved, then this kind of a sort of making hay while the sun shines would not have happened during the pandemic if humanity was still in place. I think somewhere the humanity part of it is missing, and we forget that at the end of the day, every one of us is a patient. Someone is a loved one who needs a hospital care, and all of us at some point of time have to visit a doctor. So I think if we really have to move to value-based healthcare and keep the interest of the patients and communities in mind, we have to look through the lens of the people who use those services and then design the healthcare systems that are responsive to them.
No, no, very well said, ma'am. In fact, I think the value based is now needs to really be actually converted into something that gives a collective action response. So Coming to coming to your last line, let me go to Professor Joshi. Professor Joshi, you have actually looked at the entire development of SDGs from a developmental side altogether. I mean, looking at the kind of credentials that you were, the kind of corporates as well as government bodies that you've been able to work with, and also the last mile people, which is artisans down in Gujarat, or maybe at areas which where accessibility to the last mile healthcare facilities is actually not sometimes available, and that too, like basic things. I mean, we're talking about simple maternal and child health areas which are where even safe delivery is becoming a challenge, or even the basics like an RN4 tablet becoming a challenge. So how do you kind of like support this entire value based healthcare when it comes to the last mile connectivity being reached?
Thank you, Dr. Rajeev. And you have rightly put up the perspective. Looking at the second largest populous country of the world, going to be the largest soon, we have to talk about, if I may just tweak the two words value and volume, we would have to go towards value for the volume, and it is not either or kind of a thing, and that's exactly what India is looking for. We have to take quality healthcare to the last person, and with the geographical limitations that we have, particularly in rural India, you rightly pointed out, in some of the Adivasi areas, or even if you go a few miles away from the major cities, you may find that certain kind of facilities are just not available. Some of the efforts have been made by some of the large hospitals, like telemedicines and all that. Some of our friends will dwell a little more on that, because their expertise in that. But I'm trying to say that it is a work of volume. If you just see what we have done in last 20 years in each of the targets of the SDG, particularly talking about SDG 3, which is on health in particular. I'm also trying to combine on equity and gender equity. But basically, if you just talk about only the health part of it, we have done very well on many areas. But one point that we all should put together in our minds is that while we have succeeded in a lot of targets that we have done, you talked about the maternal and child mortality and all that, we have done very well on that, and we continue to do better. The point is that external environment is always very dynamic. It throws up new challenges, and therefore we need to be conscious and not be complacent about that what we have done. And by one standard, we have to see that India, if attains all its targets, we will be taking care of 50% of the global targets. Now, if that is the kind of burden that is there on us, we need to work faster than what we can do, and that's where the challenge that all of us are dwelling today on, that we have to talk about it. That is to, we have to do a real collective action. Now, in that, we have to broad base the stakeholders. That mention was made about the stakeholders, but patient, doctors, caregivers, and the pharma companies, these are not necessarily the only list of stakeholders. We have to look at the family members, and the last mile caregivers, and other people who are a part of it, and of course educators. You cannot just leave them. I come from that background, so I definitely take the responsibility. And it is coincidental that today there is a discussion happening at the United Nations Prime, where everybody, the discussion is happening of how B schools can come together to try and, when you're talking about quality, you are definitely talking about the systems and processes and other parts of it. And it is happening today. And it's so nice that we are all coming together, and of course, the technology is something which we will have to take care of in years to come, to try and see that we take advantage of technology. But I want to leave one thought that ultimately, when all that which we talk about, who implements? It's people.
It's people.
So it is
Exactly.
always you have to talk about the training, the positive attitude, the professional attitude, and the way you deliver quality. And I'm talking about not only the doctors, I'm talking about everyone who is in the link. You know, whether it is
Absolutely.
the supply chain or the caregivers or the back office people, everybody have to come together. And how can we do that? To my mind, it's a big task to do work on. And if we are able to start there, about changing the quality services that each one provides professionally, we would be making a beginning somewhere. So
Absolutely, man. Very well said. I think your value for volume, the industry academia link that we need to really take forward is something enabled with technology is going to really take forward. The value for healthcare for all that we really enshrine towards this universal healthcare day itself. One important thing you also mentioned was the entire external environmental challenges that are being faced, and you talked about the population when will become global, and there are too many dubiouses that India is becoming global on, whether it's on NCDs, whether it is on environmental challenges. So I come to Dr. Mahesh, sir, Professor Mahesh. Very interestingly, while the world talks about sustainable development goals, the world talks about universal health coverage, the interlinking is very much evident. We see environmental challenges, the entire climate change spiel that has been discussed at the United Nations. The COP just finished a couple of weeks back, and we saw how nations committed towards having value towards not only environmental protection but also diseases. So disease has now become a universal thought, and your areas are real time areas which lead to diseases that people seldom relate to it. Down at a village level, a lady who is using someone like a chula will be not only exposed to COPD asthma but also has other challenges that are required. That equitability is not yet achieved, and we are inching towards 2030 and looking at the kind of pace right now which was stalled by almost 3 years, stalled by COVID. It's how do we look at an equitable, foreseeable health future?
Dr. Rajiv, and I think we need to look at when we talk of the climate change and we talk of the women with biomass. I mean, we have been working with biomass COPD, for example, for the last 15 years, and what the burden we are trying is than cooking 3 decades ago, right? And if you see, when we started, we are the only cohort in India which has been following these people in the respiratory system for the last 15 years. And what we realized is big impact that has come on this is due to the Pradhan Mantri's Ujjwala program. Now that has a big difference in the south. When I talk to my colleagues in the north, they do feel that it has not yet had the kind of impact that it has a potential to. And I think this will create a big difference. We are working with the IIT Madras, who are now looking at developing chullas which don't give the same amount of air pollution, with almost 50-60% reduction, which also can help to reduce the burden of disease. It's not just asthma, it is COPD, it is pneumonias, it is including if the pregnant woman is cooking, it starts from the antenatal complications to the postnatal complications, early childhood mortality. So throughout the life cycle of a human being, exposure to this indoor air pollution, outdoor air pollution has a impact. And that would need collective action, starting from not only the doctors who make an early diagnosis to counsel the patients. So probably, actually we tell them, if you have access only to firewood, please cook outside, don't cook inside the house. At least that will reduce the personal exposure and the risk, because they don't have too much of an outdoor air pollution like a city or a Bombay or Delhi. go to the house and your risk will dramatically come down, your children's risk will dramatically come down. So that is something that you can do. Now, when we talk of value here, one thing we look at is the skill set of the doctors. And I think the Indian doctors in the tertiary care are better than the best in the world. To give you some examples, my friend who was in US, he came to India to get his cataract surgery. He's running 46 centers in allergy and asthma in US, but he comes to Bangalore to get his cataract surgery done. He goes in the morning and is out in the afternoon. Within 3-4 hours, he said, in US, this is impossible. A doctor working in US, this was published in 2 months, she's working in the hospital where the surgery is available, but she comes to India because 2 months it's impossible for her to get her surgery done for her mother. She comes to Bangalore, within 2 days surgery is done, within the next 5 days she is back home. So Indians have, I think, the best of the healthcare at a tertiary level. They can go to any hospital, they can meet any doctor. It is impossible in the West.
Absolutely. No, that point I completely agree. But I think this is largely triggered because we've invested more into the entire, tertiary care technology advancement. So, here, my question was largely, how do we get that outreach to an optimum level? Is technology going to be the case? Dr. Ratnadevi ji as well as Dr. Joshi, both of them mentioned about capacity building. That's going to obviously, promote it. But, a very interesting thing on how technology can actually take that equitable and promotable healthcare. That's where I was largely talking about.
Here I think the telemedicine is going to have a major role. Yeah. I do believe in that. As part of the Lancet Citizen Commission initiative, we are now reviewing all done so far for the last more than 2 decades. And we have been screening about more than 5,000 papers. And I can tell you that the possibilities and the potential of the telemedicine is enormous as far as the diagnostic capabilities are concerned, as far as the preventive and counseling capabilities are concerned. These days they can send the blood anywhere, and then the doctor can with the telemedicine. There is no need for the patient himself actually to go to the city to meet the doctor. And most of the diagnostic facilities for almost all the diseases can be done like that. I have my colleague in Bangalore who has developed a telemedicine setup in which you can put your stethoscope there. A non-medical person and the doctor sitting somewhere else can hear the lung sounds or the heart sounds. ECG, data transmission is amazing, and that is one way in which we can reach the last mile. And the government itself, the program is there. I wish that it would, more and more people would take it. Now more than 150,000 consultations are happening every day in India using telemedicine. So that is the power of telemedicine.
No, absolutely. I think you're completely well versed in that. Yeah, because the National Digital Health Mission under Ayushman Bharat is actually also promoting a similar kind of a spiel that will be really taking forward the last mile connectivity also. Let me just switch gears here and come back to the industry. So, Dr. Rajesh, one thing when you talk about, and one thing what we within the industry loves to talk about is invest more for a better future. How would you synthesize this particular acronym towards an equitable healthcare future when we talk about invest more for a better future from an industry perspective?
Yeah, so thanks for this question. First of all, that is going further, that the artificial intelligence will play important role, and also Dr. Mahesh has also cited certain examples. So going further, I think that the investment should be more there on this artificial intelligence, then about telemedicine, then the counseling, then also based on the DNA, what is the right prescription? Because currently we are getting medicine based on that a particular dose, like say paracetamol, 500 mg and other thing, and that is across. But in future, That is, it may change. That is based on that is the patient's DNA. It will be changed accordingly. So more investment is required on this part. Simultaneously, there are certain diseases like oncology or the cancer treatments are concerned. There's a more research investment is required.
No, no, I completely agree. In fact, the government has introduced a couple of schemes like the PLI scheme, the Production Link
Yeah.
Incentive Scheme. These schemes are really, mooting manufacturing here in India, whether it is the pharmaceutical manufacturing, the APIs. In fact, to a large extent, we were dependent on APIs from China and other markets to source around. And today we've got enough companies who are coming into APIs. And again, medical devices. I mean, if you look at India is almost like 80% import dependent on medical devices, and with the kind of PLI schemes, at least the critical care areas of medical devices is where we would be able to reduce import dependency. So those areas are certainly welcome in terms of investments. Can I get back to Dr. Ratna Devi ji? Ma'am, we've looked into the entire spectrum of healthcare, from a private provider to a public health facility to even how the government through Ayushman Bharat would want to talk about the last mile connectivity. I don't think we can see her here. But nonetheless, I think a similar question can be posed to Professor Joshi also, because it's almost in a similar manner that we look at. So either ways, either Professor Joshi or Dr. Ratnadevi, you could respond to this. When we talk about vertical critical care, when we talk about patient journeys, when we talk about the continuum pathways of how healthcare could be really focused upon with these large national programs and also the state-centric programs that are there. For instance, in Gujarat, there is this Ma Yojana, and then in Andhra Pradesh or Telangana, there is this, Arogyashri scheme, etc. Coupled with the Ayushman Bharat scheme and also the entire other schemes that we have, the UHC fit, a universal health coverage fit, sometimes never happens. How do we dovetail that? So either of you, ma'am, could respond to this. Professor Joshi, you're on mute. Ma'am, if you could unmute your yeah.
I'm
Yeah, now
unable.
you're audible, ma'am.
So, from the systems perspective, there are questions of capex, and opex here. So here you are talking about the large scale capex which is required, and that's where the center and the state governments do come in, and the resource allocation, which needs to go up. And I think a good amount of thrust has been put up again on trying to increase the resource allocation to health, particularly post-pandemic. Of course, that was a big toll on us, but nonetheless, looking at the future of it, it's just not enough to have an increased life expectancy in our country, but it is also the quality of life that is which is very, very important. And I would want to tell you that this particular question, the government is struggling at present right now, where we are how do you give the same quality services to the poor as much as somebody who can afford it. And there is it is important sometimes for a panel like this to identify the issue on hand. If we are able to identify and talk about it, we'll be able to find the solutions to it. And that is why,
Absolutely.
I mean, the point to me is that we presently have this as a gap, and all the stakeholders need to come together, and a lot of it can be done by a huge number of not-for-profit organizations. They are doing fantastic work across the country. We have seen a lot of volunteerism happening during the pandemic, but there are health agencies already working, and they're doing some fantastic work. I think there's a need for putting all the best minds together, not simply talking about NGOs working in certain kind of ailments and not in the other, but we need to all look at the health per se, and we need to really define health as that, as to how do we define health. As earlier we were discussing about providing pure water and better air would get into providing better health, and then investing into that would also mean investing into better health for all, and
Absolutely.
then of course water and health is commonly available, and therefore it will reach out to everyone, and there'll be no discrimination caste, creed, or location wise, or gender wise, and it would be made available to all. So to my mind, this question needs a little more dwelling, where people come together and decide the resource allocation into what are your priority areas and how do you go about looking at it. And Dr. Ratna,
Absolutely,
please.
absolutely. No, no, no. You said it very well. You said it very well. In fact, Dr. Ratna Devi, ma'am mentioned about a very good thing is that you need collective action, whether it is from an NGO, whether it is from the grassroots level, whether it is from the state or the center. I mean, I heard one of my mentors talk about a PPP model, and this is like not the regular public-private partnership, but it largely talked about the PPP as a partnership for a public purpose. So, when we talk about the quantum of healthcare and universal health coverage, how would you define this PPP so that larger action can be really taken forward?
Thank you. And I lost the connection when the gentleman was talking about telemedicine, and I'm sitting in Gurgaon. So we can imagine the digital divide that happens, when technology jumps in onto an already fragmented, very fragile healthcare system.
Yes.
So having said that, just to answer your question, I completely agree with what Professor Joshi said. It cannot be any one industry, one government, or one state that can manage this kind of a volume that we have in terms of the populations and the disease burden. And we've also heard the previous panelists say that health is not just a function of health ministry itself. A lot of determinants, especially the commercial determinants of health, lie outside the health domain. So whether it is water, whether it is sanitation, whether it is electricity, environment, so many things where industry has a big role to play. So I think to be able to make universal health care a reality, what has been spoken of for a very long time, saying health for all and all for health, has to actually become a mantra in every ministry, every industry, and every human being that is working for this purpose. So unless we have clean environments, clean water, clean sanitation, clean roads, and all the infrastructure that is required to live a healthy, happy life, just providing an infrastructure where doctors are managing the sick people is not going to help us achieve universal health coverage. Universal health is not about getting cured once you fall sick. It is about the prevention part of it as well, about keeping people away from sickness so that they spend as less time as possible in the hospital, and therefore the burden of spending for healthcare reduces automatically. And that can happen only when the community, the government, and everybody comes together as one voice and looks at health as something that is has the ownership from everybody. Right now, the patients think that the government should give them everything free of cost. The government thinks that the people are not responsible enough, and they fall sick because they do not manage their health care well, and therefore this blame game goes on. It is not helping anybody. There has to be ownership from both sides. Patients have to understand that healthcare is their responsibility. If they have a right to good health, it is also their responsibility to maintain good health. And at the same time, it is the responsibility of the government to provide healthcare that is, safe and equitable.
Absolutely. Well said, ma'am. In fact, your last point takes me to Professor Mahesh. Sir, ma'am really elucidated it in a very succulent way where we need all hands on the deck right now. As a clinician, someone who's largely, working around in a large healthcare facility where we talk about, how healthcare can be really derived through clinical trials, through, the entire clinical setup itself. What would be your 2 cents to describe to build quality health systems that people and communities can trust?
I think here in this, with the rapid advent of the technology, I think there is a big role for the artificial intelligence. You see, now
Yes.
I was working with the Regional Engineering College in Surathkal, and we developed a software that's using the machine learning technology. It just an X-ray, it will tell you whether it is COVID or it is not COVID. It will tell you normal, COVID, or pneumonia. And it can be done by a technician. You don't really need, and we tested in all the data sets that's available from the West, and data set from our own medical college hospital, with a more than 95% success rate. So using artificial intelligence for the diagnosis, to develop the diagnostic, cannot know the guidelines because there are too many specialties he has to deal with. But using an artificial intelligence, he can just put in, or the nurse can put in the patient's data, and they can get access to algorithms, how the patient should be triaged, which can be managed in primary care, which can be managed outside. So this kind of a triaging can help to optimize the last mile. So I think artificial intelligence is the way to go, and that can use, it can do an enormous amount of work. You can put 1,000 X-rays at one go, and it will give you the reports from, for all of them. And you would not have a radiologist who is, really good, because normal people find it difficult for something like COVID. So using an artificial intelligence would be the way forward.
No, absolutely, sir. I think you've ended on a very right note that technology-enabled healthcare systems can really, really take forward the entire vision of ensuring strong and equitable healthcare that leaves no one behind. And we are privileged to have Dr. R.S. Sharma, sir, join us for the session, and for the benefit of the entire panel as well as the speakers. It's my honor to also introduce Dr. Sharma. Sir, are you able to hear us, sir? You're on mute.
Yes, I'm able to hear you. I'm just joining
Namaskar, sir.
now.
Namaskar, sir. Namaskar. Really, really privileged to have you on this session, sir. And we've had a very enlightening 1 hour, and I'll give you a gist of this. But before that, let me introduce Dr. Sharma. Dr. Sharma is presently the CEO of the National Health Agency, the Ayushman Bharat mission, which each and every Indian now looks forward to. He is also responsible for managing the entire Ayushman Bharat Pradhan Mantri Jan Arogya Yojana PMJAY and the National Digital Health Mission also. And he also serves as the chairperson of the Empowered Group on Vaccine Administration for COVID-19. Previously, he was the head of TRAI, that is the Telecom Regulatory Authority of India, and he's a decorated IAS officer of the 70H batch. And he's had so many posts within the government of India, notably as the Director General and Mission Director of the Unique Identification Authority of India, which India got its true technical or technocrat freedom, as we normally would like to call it. Dr. Sharma also had Rupa Publications come up with his book, Making of Aadhaar, which is the world's largest identity platform, which has been very well received within the country and global also. So, Dr. Sharma, just to give you a small, quick 30-second brief on the entire panel that we had, we've got a very illustrious panel which has people from not only the industry but the development sector as well as a clinical setup, and we also have Madam 𝗙𝗲𝗡𝗢𝗄𝗎 from the United Nations, and it's actually 3 a.m. in New York that she's attending this particular conference with us. So, ma'am is there. She gave us a very well balanced view on how financial constraints, corruption has really led into the medical fraternity not looking towards universal health coverage. Then we talked about, the entire panel talked about how more investment into better healthcare is required, where we need to sustain public financing and harmonize health investments. We also spoke about how we need to regulate and legislate the entire healthcare system itself to create a strong enabling regulatory and a legal environment where it is responsive towards the poorest of the poor also. We also talked about how we could uphold the quality of healthcare by building quality healthcare systems, especially the primary care systems that are required in the developing and the underdeveloped countries. And India has really reached out through Ayushman Bharat, the last mile connectivity also. So that becomes one of the case studies that a global populace can actually study. And last, we just were talking about how AI and value-based healthcare can enhance accessibility, affordability, and accountability, the three A's that the Honorable Prime Minister talked about, and taking forward the entire quality aspect that he talked about from the Red Fort itself, called Jai Anusandhan. So, sir, with this, we would request you to give your valedictory keynote address.
Thank you very much, Dr. Chibbar, for that very, very generous introduction and also giving an overall sort of view as to what has transpired or what has happened in today's deliberations. First of all, let me congratulate Voice of Healthcare for organizing this discussion on this Universal Health Coverage Day. It's really appropriate that we have this discussion today, and also the fact that after this huge pandemic which has really devastated the entire world, this is a time to recognize the primacy and the of the health in the entire kind of economic development paradigm. So I think this is really something very good which you have undertaken, and I must compliment the entire team which is actually been responsible for organizing this discussion. Also, the fact that you discuss this entire range of sort of topics, especially how technology can enable the provisioning of health services in an affordable, accessible, and quality manner, is also an important aspect and dimension of this. And we have all come to realize, during COVID times, especially in India, we were all closeted in our homes and were not allowed to go out. And in those difficult times, the technology and the communication systems were our only help. And we were asking, our doctors, either through WhatsApp video calls or messages, and asking for their advice. And then, of course, asking the delivery of medicines and food and everything. So I think we have learned in a way as to how technology can come to our help even in difficult times. So I think that has happened. That's the only positive outcome, if I may say, of this COVID pandemic, which basically has told us or taught us to use technology. Fortunately, India has had an extremely robust, ICT infrastructure, in the sense that we have 1 billion mobile connections. We have the cheapest data rate. We have, large number of smartphones now, which can actually use various kinds of applications. So I think that was one very good, thing which have happened. Let me share with you as to what the National Health Authority is doing in this particular area of healthcare. So one is, as you may be knowing, and maybe many of our panelists and the sort of audience may be aware of the fact that we are implementing what is called the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Now, this is actually a scheme which targets 40% of the bottom of India's population, which comes to about 500 million population, and which provides a health assurance for in-hospital kind of cases. So basically, we don't take care of the OPDs, but we certainly take care of of the situations where you have a catastrophic health, sort of emergency in the family, or, somebody gets hospitalized, then we do take care of the entire expenditure prior to hospitalization as also post hospitalization 15 days after that. So that is something which is actually the largest kind of health safety scheme in the entire world. And all states except a couple of states, 2 or 3 of them in this country, are implementing Pradhan Mantri Jan Arogya Yojana. And we have thus far, it was launched in September of 2018, and now we have December of 2022. About 4 years of running of this scheme, we have actually catered to about 440 million hospitalizations, which is about 4 crore hospitalizations. And we have spent about 46,000 crore rupees on this scheme. And on an average, we are providing, we are processing about 1.2 million claims per month, which is about 40,000 claims per day. So we have actually our digital platform caters to about 40,000 admissions every day. And now slowly, because of the robustness of our digital platform, we have expanded the scheme to cover many other vulnerable sections of society. So we are actually covering, let's say, transgender population. We are also providing our digital platform to many other schemes. And the list is increasing. The ESIC and EPFO and other kinds of systems are actually going to be put on this platform. And the beauty of this platform is that it actually deduplicates, in the sense that it ensures that one person is not able to double dip, which means he or she is not able to take advantage of 2 schemes, number one. Number two, it is real time, in the sense that as soon as you go to the hospital, immediately, if you are eligible for that scheme, you are pre-authorized and you are able to take treatment. So you don't have to wait, and you don't have to get into a lot of paperwork, so to say. And the entire process end to end is digital. So basically, from the pre-authorization to the discharge to the payment to the hospital, everything is in a way automatic and digital. And we also believe in the public private partnership. So we have a 28,000 hospitals on our panel, out of which 14,000 are public, and the same number is around private. So it's a true public private partnership scheme. And now, the last panel was talking about the value-based care. We are introducing value-based care. We have an extensive set of health benefit packages, about 2,000 of them, which actually take care of almost every disease, with cancer and even dialysis and many other all kinds of diseases which you can conceive of, which are there prevalent. They are being catered to by under the Ayushman Bharat JY. So that's one part, and we are very happy, because we know that when a poor person gets ill and he gets hospitalized, sometimes most of the time he or she is not able to afford the treatment cost, and actually that puts him back to under the poverty. So basically he goes down again, his income goes down, he has to sell his assets, his house, his cattle or whatever. So that's basically, we cater to ensure that the out-of-pocket expenditure in such catastrophic diseases is basically zero. And we are introducing technology again, because the Honorable Prime Minister had launched in August last year an instrument called e-Rupee. Now that e-Rupee is a digital voucher which actually we provide to the patient to basically get medicines from out of the hospital, to get the diagnostic test done, so that he or she does not have to spend anything from his or her own pocket. So that's one scheme which we are implementing. The other one which we are implementing is Ayushman Bharat Digital Mission, which was launched by our Honorable Prime Minister on 27th of September last year. And that scheme essentially, ensures as to how we can use technology to, make healthcare more affordable, more quality, and more available to everybody. So the 3 things which you talked about: availability, accessibility, quality, affordability, all these, aspects, how we can use technology to the maximum extent. So, for example, how we can use the teleconsultations, how we can use digital prescriptions, how we can actually find out, have a list of all the authenticated hospitals, all the authenticated health providers, professionals, and therefore, and how a person can have digital sort of repository of his longitudinal health record. So basically, we have created a number of digital public goods, as we have done in case of identity, in case of payment. Similarly, health is actually one of the important domains where we are connecting the dots, all these things which were being used, technology tools which were being used in a sporadic and disconnected manner and silo manner. We are actually providing a framework to essentially ensure end-to-end provisioning of the digital, of the healthcare using digital means. So, for example, we have the personal health records of a person where he or she can store the health records and can share with the doctors or service providers. We have the health professionals registry, which is basically an authenticated registry of all the healthcare providers in the country, which are actually authorized and actually which are genuine healthcare providers. It actually eliminates quacks, for example, from this list. We have the health facilities registry, which is actually again authenticated registry of all health facilities in the country. We are going to build a digital drug registry, which actually will provide a complete sort of repository of drugs which are being used in India and their, sort of compositions, salts, and equivalent drugs and generic drugs. All those things are being built by the National Health Authority. So the whole idea is that we are able to build an entire ecosystem of all the stakeholders who can participate in this, provisioning of the healthcare services. And citizen is that the focus of it. And let me also say that this is a truly public-private partnership project. We are not building end-user applications. We are not building the health service providers' applications. We are just building a framework, and everybody else is welcome to plug into this framework their applications. So we have approximately more than 1,000 partners who are working with us in our sandbox and are creating end-user applications, whether they are the personal health records or whether they are the teleconsultation. And this entire framework is completely open-based, open source, open APIs, open standards. So and interoperable. Interoperability is extremely important in our context because we are a very large country. We are a very diverse country. We speak multiple languages, and we are at a different stages. Some people are completely illiterate. Some people are absolutely, masters and doctors and all that. So we have to cater to the entire. So inclusion is also very, very important. Inclusion and the interoperability. And we are building that interoperable ecosystem, which actually is ensuring that anybody, any application is able to connect to any other application. So, for example, if you have video consultation application, an individual has got A and the doctor has got video consultation application B, A should be able to talk to B without bothering as to what application doctor is on and what application the patient is on. So that is a true power of interoperability, which actually we have seen in UPI, Unified Payment Interface. So it doesn't make a difference as to which bank your account is in and which bank you want to transfer to. You can do that absolutely seamlessly in a very, very hassle-free manner. And that's what we are building in this health space. In fact, India is building in a digital commerce space also. A similar experiment is being done. You must have heard of the Open Network for Digital Commerce, ONDC. So these are the broad philosophical underpinnings of our digital transformation which we are undertaking, which is essentially open, interoperable, inclusive, open source, open standards, open APIs, frugal. We should be absolutely, because we are aware that the India is an extremely sensitive market, and therefore it's very price sensitive, and therefore if we build very, very high, costly applications and costly things, it will not work here, and people cannot afford it. So affordability is extremely important. So these are some of the basic principles, and what is happening is that stakeholders and all hospitals, laboratories, doctors, everybody is coming together, believe me, and we are all working together to make an extremely ambitious, sort of ecosystem which will truly transform the delivery of healthcare in this country. And we look forward to the support of everybody, even in this audience, even in this panel. We want everybody's support so that we can work together and we can make this entire thing absolutely, robust, safe, secure, privacy preserving, and ensuring that everybody is able to. It's a win-win-win for everybody. That's what we are looking forward. That's where I would like to end my intervention. Thank you once again for inviting me to this panel and allowing me to share my ideas and thoughts. Thank you very much.
Thank you very much, sir. In fact, I had a couple of questions for you, but then your speech was so eloquent that it answered all the questions that we were actually prepared for, whether it was on disease demographic profiling, whether it was on genuine healthcare registries, or drug registries also, which is becoming more and more important these days. Citizen focus. In fact, we've got Dr. Joshi and Dr. Ratnadevi here, who are largely looking at how the entire developmental aspect can be dovetailed into it. And also the larger thing that you talked about is interoperability. Sorry. So that's something which we are actually, we were thinking to actually question you on, but it's your magnificence that you've already responded to all of this. But yes, with this we come to the end of this session, and I like to thank UN Global Compact Network here, because, sir, just to give you a brief gist on the UN Global Compact Network, this is the largest corporate sustainability platform that functions to implement the SDGs here, and the UN 10 principles in the areas of human rights, labor standards, environment, and anti-corruption is something which they're focusing on. So health is something which also is dovetailed when you talk about sustainable development goals, and everyone here, whether they were from the private sector, whether there was a clinician, or whether from even VOH, our organizers, they've been immensely able to add a lot of value into this. And thank you very much for your eloquent and your pointers that were really, really required to make this a success. Thank you, sir. I'll hand it over to 𝗔𝗓𝗄 for the closing remarks.
Thanks, Dr. Rajiv, and thanks, Dr. Sharma, again for your time. Thank you to all the speakers again for enlightening us with this discussion. We do have other series of discussions in line. So once again, thank you to all the speakers, and thank you to UN Global Compact India for supporting us so well for this discussion. Thank you.
Thank you very much. Thank you, ma'am. Thank you. Have a great sleep, ma'am.
Thank you, everyone. Bye.
Thank you.
Good afternoon and good evening to everybody who have participated in this webinar, which is extremely appropriate and is top of the mind today. Very clearly, health is an issue from which no one is isolated. Therefore, the interest levels are extremely high as to how we as a nation are taking care of our health. The Ayushman Bharat program launched by the Prime Minister has seen 2 or 3 avatars in its evolution. And this is bound to happen with 1.4 billion people, the most populous country in the world today. We will not be able to say in one go that we have adequately covered the entire country for health to the expectations. And why I say this is because expectations have to be in tandem with what we have. That's extremely important. We are a very diverse country, both from a geography perspective as well as from a socio-economic perspective. Challenges are huge. Having said that, we are very, very proud with this initiative to provide universal health coverage by 2030, which is really a dream come true so many years after independence. So without much ado, the intent of this webinar is to have an open dialogue and discussion as to the challenges and successes, and what very importantly, I believe, that health is not alone. It is also the responsibility of individuals. So you cannot shy away from the fact that we as individuals are also responsible for the success of this program, as well as we are responsible and accountable to ourselves as to how we lead healthy lives. So without much ado, I would like to welcome Dr. Priyanka Das, who is the Mission Director, National Health Mission Department of Health and Family Welfare, Government of Madhya Pradesh. Welcome, ma'am, to the program. We are committed as a nation to achieve universal health coverage but for all citizens by 2030, which is fundamental to achieving the SDGs. Given the challenges, as I mentioned, and the vastness of our country, where do you see it moving in Madhya Pradesh, and what are the success stories, and on the other hand, what are the challenges that you foresee in achieving this goal? Over to you, ma'am.
Thank you so much. As you mentioned, achieving universal health for all is indeed a daunting task for a country which is as huge and diverse like ours. But what I foresee as a positive change is that we have now put the right kind of institutions and policies in place in order to achieve this. Nationally, the concept of Ayushman Bharat Health and Wellness Centers proliferating across the state and across the country is a big welcome step. You must be aware that a new cadre in the form of community health officers are being posted. So now we can say that achieving universal health for all is becoming a tangible reality. Having said that, it does not mean that earlier nothing was being done. We definitely did have the sub-health centers, but their upgradation into health and wellness centers and posting a new cadre has brought in a kind of a sea change. Why I say so is, if we talk about Madhya Pradesh, we have more than 10,000 health and wellness centers, and we've been able to operationalize every single one of them in record time. And Government of India has lauded our achievement for the fact. And we've been able to train our CHOs. So once this cadre is in place, the earlier the expectation from any health worker was that we would only only take care of the maternal and child health aspects of the population. So it was usually the ASHA worker and the Anganwadi worker and the ANM would see to it that the pregnant mother has received her vaccinations. She's given her iron folic acid tablets and her calcium tablets, and the child is immunized. That was the primary goal, few decades back. But now the mandate for the community health officer is an expanded range of services. So when we say universal health, it means all kinds of health issues. So now the CHOs are being trained on, basic emergency care, on palliative care. Earlier in India, we hardly used to talk about palliative care. Now we are talking about mental health. We are talking about ENT and oral health, and all these 12 kinds of services through the CHOs. So one, we have expanded the basket of services which was earlier not available in the rural areas. Secondly, what we have done in Madhya Pradesh is we have revised our EDL list. It's an essential drug list. Earlier, we were very conservative about the fact that only these many kinds of drugs should be available in a sub-health center. Recently, the state has taken an initiative and has expanded its EDL list. And we have also, introduced a mechanism of teleconsultation. So through the teleconsultation, what we have to do is we have ensured a system wherein a specialist teleconsultation is done, and the doctor who is consulting is prescribing our EDL drugs, so generic drugs. So that's how we are improving the accessibility of our drugs and our teleconsultation and medication services to the people at large. So I would say these are the two specific contribution that Madhya Pradesh has made, expanding its EDL list, expanding its range of services, and also enhancing the kinds of tests that are available through our hub and spoke model, so that the villager does not have to travel long distances. His out-of-pocket expenditure is minimized, his time, resources is saved, and along with it, we are able to offer quality healthcare services.
You've mentioned, ma'am, once or twice on the cadre part, right? And if I remember correctly, in the Finance Commission, the 15th Finance Commission, there is a reference that perhaps India as a country would, just like you have the IAS, IPS, and other central services, states, since health is a state subject, they might look at a medical cadre, right? Wherein there would be an expansion of the kind of people who would be there. Would Madhya Pradesh at any point in time look at it? Because clearly from what you have mentioned, the success is largely, I can't say 100%, but surely largely based upon this brilliant work that you have done with the community health workers. Would that perhaps help and facilitate it?
To this, I would respond, see, health system itself is quite complex. And when we talk about manpower, at one end, we require, grassroots workers like ASHA, ANM, and CHOs who work at the community level. Then at the facility level, as we, gradually go higher up from PHC right up to the district level, the quality of skilled manpower changes. So from regular MO to we want specialists, we want, other kind of, lab technicians, pathologists. So a lot of other specialization cadres and amenities come into the fore. And apart from that, what we usually do not realize is that we also require a health managerial cadre. It is not only about the clinical treatment part of it. So what we have done in Madhya Pradesh, I'll be happy to share. We have actually structured our health services into 4 kinds of, I would say system, not exactly a cadre, and we are restructuring it. And we've also, built in promotion mechanisms so that any public health personnel, if he or she chooses one career path, then there is some progression to it and there's no stagnation to it. So we have kept, the clinical part. and we allow our people to enter as, say, MO, medical officers, and then we give them we open up 2 tracks. One track for becoming a public health manager, and the other, if you want to pursue specialization, then you solely remain in the clinical part of it, and then you become a clinician. So there we are opening up 2 trajectories. So for the public health manager, what we are asking is that you should have at least field experience of 5 to 6 years. You should be a MBBS graduate, and you should also have a diploma or a degree in public health management. Then we are opening up the track that then he or she can essentially become a block medical officer who will manage the entire block, and then can be promoted to become DHO, then CMHO, and then finally JD, and then can come in at the directorate level. And for the others who continue to be in the specialization field, they can progress as MO to PGMOs, then they go on to become civil surgeons, and then they also gradually become JDs. So they will be heading the super specialty field. So these 2 career options we've opened up. We want a third cadre, which is a sort of contractual cadre who will assist. So they will usually be the data assistant, the lab technicians, the pharmacists, this kind of a supportive staff sort of a cadre, and which will essentially be managed by the public health managers. So some sort of restructuring we want to initiate in the state, and we've been able to start this public health management cadre. And recently in Madhya Pradesh, now we've already trained 2 batches of our people, giving them basic administrative training, like mob handling, media handling, how to answer in front of all different kinds of judicial, medical, legal cases, how to financial aspects of it, accounting of it, because suddenly we assume that a person who is a doctor who's been treating, say, for 6 years should become a manager and should be able to run a hospital or an entire block and command the respect of all the other health workers overnight. It doesn't happen overnight. So we have invested some time and energy in the training part of our managerial cadre as well. So this is what we've done in Madhya Pradesh.
That's absolutely brilliant, ma'am, because if I go back in history, as a clinician, being pushed into administration was a really daunting task. And at that point in time, I was the founding dean of the hospital management program at the Indian School of Business. And exactly the areas that you mentioned were areas that one realized when running the hospital, this is least looked at. So I think that's a brilliant way forward. And the focus that you're giving on the paramedics, I'm sure it would be a template that the rest of the country would also definitely should gain from your experiences. Thank you so much for that input, and then I'll come down for the second round of questions. With that, if I can move now to Dr. 𝗙𝗓𝗄𝗏. She's the Mission Director, Director Health Services, Department of Health and Family Welfare, Government of Sikkim. Welcome, ma'am. As part of the National Health Mission, we have 2 schemes, RKSK and RBSK. So both of them, from what one understands, is that we're trying to look at the developmental phase, meaning you start with children and then you get into adolescent health, as being a very critical component, because presumably that is why these have been hived off in 2013 and 14 as independent missions. So in your viewpoint, is this the right approach to have them as standalone missions? Does it bring in operational efficiency? And what are the challenges that you have found in implementing it? Because they have so many subparts to it, different goals, and within those goals, looking at a cohort of people who are not truly independent till you come to adolescence as children. So over to you, ma'am, for your thoughts on this.
Okay, good afternoon. What I would like to say is this RBSK and RKSK programs, which was basically aiming to serve the children and the adolescent, which is a huge part of our, 1 billion, populated India. almost, I think, 1/3 are small children, and 1/5 of the adolescent population is there. So since they are the future of the nation, so the starting of this service, the program of RBSK and RKSK was actually very, very good. Now, it started around 7 years back, but as we all know, due to the pandemic, the last 2 years, we could not follow up to all the programs. But as per your question of whether they were good as standalones, I would like to disagree, because everything is integrated, and not only the children are integrated within the various, the programs of the health department, but it is more of, integrated with the rest of the line departments also. So I think RBSK started with, mainly the 4 Ds, the defects during, birth defects, disability, then developmental disability, then those diseases. Those things, like if you take it standalone, actually we cannot, give full service or full credit to it. So the integration, the holistic part of it, which was taken over along with the social welfare department, which has the Anganwadi centers, where we catch these newborns and the smaller children, age group from 0 to 6 years. That integration was actually much needed, and it's good. That is how we could catch the very small children in the villages and in the urban areas also, where the ICDS is functioning. So I think standalone would not have done justice. And regarding the, the RKSK, Rashtriya Kishore Swasthya Karyakram, that is the adolescent. Now it is very multifactorial, the adolescents in our country, in a huge country. So we have so many school students as well as many dropouts also. And there is also early marriage in many of the states. I think some of the states, they have early marriage also. So we have a huge group of adolescent which are, not a single type of adolescent. They have varieties, rural, urban, they are different, they are in schools, out of schools. So like that, a multi-pronged, program has to some extent helped in giving service to these adolescents. Whether it is we have a huge, like, as in Sikkim, I can say, like we have this high suicidal rate, and our TFR is very low, and mental health issues are there. We have very high literacy. The literacy in Sikkim is very high. So probably we are facing the challenges which happens in a developed country, a smaller part of it, but we have other things like, high suicidal rate and things like that. So we have the SPAN project, in fact, with along with in convergence with this from with other like AIMS and with NIMHANS also, we have the SPAN project, in which we are having studies in the community as to find out why the suicidal rate is high in our state. So these are some of the things. So the RBSK and RKSK program as such is actually very good, but until and unless we integrate it with the rest of the programs, like National Tobacco Control Program, because there are then we have these other programs like RCH, reproductive health, mental health, then only we can give full justice to the program.
Thank you, ma'am. I think you brought that point out very beautifully, that though they are, from an implementation perspective, you have these different programs, but the success of them is when you look at them holistically, and they are essentially not only being serviced by a common individual, that is the Anganwadi worker or the ASHA worker or the primary health centers. So integrating them in the entire spectrum, the platform being one, has made a success story out of it. If you were to spend just 30 seconds on birth defects, right? In birth defects, do you find it a challenge that, okay, you've identified a birth defect, and a large proportion of those birth defects are cardiac in nature? Then is the state equipped enough to have completed the loop by having adequate facilities for them to go? Or then do you have to refer them to larger centers in other states?
Well, in Sikkim, what we do is these birth defects, once they are identified, we have around 97% institutional delivery. So they are usually diagnosed by the pediatrician during delivery time. So we do not have a pediatric cardiac center as such in our state. So what we do is they are referred to STNM hospital, which is the referral hospital of the state, from the districts or from the PHCs. And then then we have a referral system. We have this hospital in Durgapur, Mission Hospital, where all these congenital birth defects related to cardiac defects are referred. And then they are referred there, and then the surgery is done there. Then they come back to us. That is how we do. Regarding other defects, like, if there is cleft lip or cleft palate and all, then we have this integration with the SMILE projects. They come here and do camps in our hospital, in our own hospital at STNM, and there also we conduct these camps. So that is how we are dealing with the birth defects.
Excellent. So harnessing private sectors, NGOs, trusts, hospitals has definitely given an impetus to be able to deliver the kind of care. I think that Ayushman Bharat program has been excellent in being able to make sense out of the PPP model, so that whatever are the efficiencies in the public sector can be enhanced with the private sector participation to some degree. So I'll come back to the second question and now move back to Ms. Priyanka Das. Ma'am, in the state, along with, as we all know, in the Ayushman Bharat program, essentially 40% is given from the center and the balance is substantiated by, it's covered up by the state. So you have the Gram Arogya Kendra Yojana, GAK, I believe is the acronym for it. And while you are dealing with the multiplicities of programs, right? And in the center, we have a number of programs, the malaria eradication, blindness eradication, so on and so forth. So in your opinion, how is this panning out? And what are the challenges you find in tracking each one of them? Because there are so many programs, and rightfully so, because they are addressing specific areas of healthcare delivery. And so what are the challenges? And amongst all of them, is there a place for preventive health? Over to you, ma'am.
Like MD Sikkim rightly pointed out, each program having a trust is important. It always helps. But at the end of the day, everything comes under the ambit of NHM. So we usually at the MD level, we talk in terms of pools, not necessarily in terms of, programs. So when we are talking about RM and CHA, we may be having 3 deputy directors, handling different program segments of maternal health, of immunization, of child health, but they all work in convergence and they have to be in sync necessarily, because if something is going wrong in the labor room, it's going to impact your SNCU. If something and the SNCU linkage is not there with the immunization division, then the entire trust is lost. Similarly, we have the other pool of, communicable diseases, then the pool of NCDs. So I would say there is a horizontal mechanism of, integrating each program, but it is very challenging. Why I say so is every program has its different portals. Everybody is guided by their, portals and their programmatic requirements. So at, at the state level, it becomes very essential to, that we rule out the duplicacy, and bring in the convergence. So that has to be, every MD usually keeps that in focus, because that's how we can synergize and get maximum out of it. So I keep telling my team that we cannot work in silos, and we essentially have to work like a team. Nowadays we are also talking about TB in pregnancy. Earlier it was not so much in the fore. So earlier I don't think my state TB officer ever interacted with maternal health so much, but now they are doing. Now similarly, like I say, coming back to the CHO concept of it, now they are delivering 12 essential services, which means that the work of the CHO is not being monitored only by the director who is looking after CPHC, but also by maternal health, because CHO is administering iron sucrose. CHO is looking after vaccination as well. So director immunization is also monitoring her performance. The director NCD is monitoring the performance of the NCD portal through the CHOs. So that horizontal layer which has come in at the field level is now also leading to a lot of convergence at the state level, when the program officers are now talking to each other, trying to leverage the worker which is there on the field for his or her programmatic performance. Another thing which Madhya Pradesh is doing, because I always be very baffled with multiple reporting systems and multiple portals reflecting varied kinds of data. So recently we have put in a person in place who is going to provide an integrated dashboard to me. So we actually have more than 23 programs running, but it becomes very difficult, or rather it becomes a tedious task to sit and triangulate the data. But now with this integrated dashboard, we'll be able to generate heat maps of our blocks. So I think, but this is something which is work in progress. We've just recently tendered it out. We were working on the concept in the first half of the year. Now we've successfully tendered it out. So hopefully once the integrated data keeps coming to us at the state level, we'll be in a better position to tweak the programs as and when needed. Otherwise, instead of mid-course corrections, usually once the result is achieved or not achieved, that is when we are able to intervene. So when we have this integrated data coming in very smoothly at regular intervals to us, and drawing from the same portals, no repetition, but we are just putting in one horizontal layer in the architecture in such a fashion that the data is visible to me. So essentially I should be able to see that if I'm having a maternal death, is there a correlation with referral transport, or is there a correlation with HR, or is there a correlation with any sort of disease burden in that particular block. Now, coming to these kind of conclusions would always require some sort of academic research and input, whereas we already have this data, but we cannot make sense out of that data. So with this integration, we'll be able to make better sense of our own data, and hopefully govern our system better, and deliver better services to the people.
Excellent. So a pet area of interest for me personally is that there is this looming threat of the next pandemic, right? I mean, we are barely out of one, but this looming threat is there, that around 2050 we will have an antimicrobial resistance thing. So I believe if you could, even when you're having this, you're putting this integrated digital platform, which is brilliant, if you could also look at infections, because at the moment we don't have any new antibiotic on the horizon, and unless we are able to figure this one out ourselves with preventive measures, we would really be hurtling towards another pandemic, of which again we will not be able to have any armory to be able to take care of it. And I think you very rightly pointed out that unless you're able to make sense of the data, you cannot get the true capital out of that data or currency out of that data to be able to move forward and action upon. So thank you very much for those inputs. With that, I will move on to Dr. Rajprabha. Ma'am, in your state, and as you very rightly pointed out, you have such a high literacy rate, which is extremely heartening to hear. You also have a program which I believe is the Mobile Village Clinic Van Initiative of the Chief Minister, 𝗙𝗲𝗓𝗂𝗂𝗓𝗂, which is instituted on the 15th of August, part of the UHC. So how do you find that this is leveraging itself in being able to achieve the goals of UHC? Over to you, ma'am.
Okay, so the thing is that Sikkim is a mountainous region. It's a sub-Himalayan region. So geography is very different from the rest of the plain areas of India. So what happens is that in certain areas, it is very difficult to have a sub-center or a PHC where we have, population of as less as 300 people. But they are, in the far-flung, hard to reach areas. So in order to have this universal health coverage and in order to give them also service, like our ma'am from Madhya Pradesh has said, expansion of services, not only RCH related, the first 6 packages, but including everything else, including palliative care, geriatric care. So in order to, reach this to the last mile person in the state, so our Chief Minister conceptualized this mobile village health clinics. So we have these, it started in August, and it has been received very well by the people. And also we have been able to, cater to almost more than around 15,000 people already within 1.5 months' time. And we have also been able to do more than around 3,500 tests. So which is actually very good. And what happens is that in every village, we are rotating, once a month sort of a thing. It is going to every village at the moment. And we are having a doctor, one pharmacist, one staff nurse, and one, data entry operator is there. So that is how they are going to villages, and we are coordinating with the ASHAs, the Anganwadi workers, the CHOs in the field, and they give the information to the public. So they gather either in the ICDS centers, or they also gather in the school or a private home, wherever it is, good for them. So they gather there, and we have this village health clinics running through the mobile vans.
Sorry. So essentially, with the mobile van going there, so you're addressing 3 things from what I can make out. You are doing screening programs there, a certain amount of curative work, and you are also doing some amount of health literacy work. Would I be correct in that? You're informing them of all various schemes, and do you also have an element of preventive health in that?
Yes. We have, we are, in fact, the whole thing, we are just rolling out. So initially it is just the curative part, giving, dispensing medicine, examining the patients and all that. But we are also having these, antenatal checkups there. We are also doing the RBSK program, the students, when we go to the schools, when we take the vans to the schools, we are doing the RKSK programs over there, IEC to the students, screening for any vision defects. Those things are also happening at the same time. And also we have this health education officers also sometimes also going and giving health education also. So it is not single just to do a curative service, but also preventive health promotion also. And we are going to expand on that. So everything is will be included so that it gives a universal health coverage. That is our main aim.
Perfect. So for the last round of questions, as being a moderator, I think I'll take the liberty of touching on some of the burning questions that we always debate. I mean, we discuss and debate. It's extremely aspirational. It's not aspirational, that perhaps is the incorrect word. So till date, we've always provided episodic care, right? So you have an acute condition, there's an intervention for that episodic care, and we move on. Now, gradually, the conversation world over is shifting towards a continuum of care, right? And thereby, in the continuum of care, we sort of string all these pieces together. Of course, it comes with a substantive cost, and it's an aspiration of every human being that I must have the best care in the world. And India, as we know, we have the largest amount of out-of-pocket expenses. We have not revisited, if I could use the word, right? Revisited what are the elements which we consider as absolutely necessary in providing care, right? So is it necessary at the level of a community health center to have bypass? Obviously not. You will not get the manpower to be able to do it. And similarly, for some other very high-ended interventions. Then comes the use of technology. So the question is to both of you, and you can take them one at a time. Do you think there is any element in a revisitation of the kind of services that we need to provide in this part of intervention, and to what level will we take them to? Because taking them to an X level, like in our clinical world, we always talk about bellwether procedures, and most of them come into those 5-6 procedural parts. Do you believe there is any merit to looking at this? Ma'am Das, over to you first, please.
As far as I am concerned, I would always welcome, more introspection, and, it never harms to think more on a subject. So it is always welcome that, bright brains sit together and, thrash out, and we can come up with something new. But I would say that COVID has actually taught us a lot of things, and there has been a paradigm shift in the way we now approach healthcare. Earlier, like you said, it was mostly episodic. Many states were trying to provide continuum of care for certain segments. For mother and child, this concept of continuum of care was already there. It preceded COVID. But the way the NCDs have come to the fore is something which is new. Government of India was running the non-communicable disease program and trying to bring in a lot of awareness and sensitivity to these things, but it did not grab the limelight as it should have. And recently, when I was having a conversation, a very interesting perspective was brought into light, that COVID actually exacerbated the situation of the NCD patients more. So more than a pandemic, it was a NCD disaster. If we can, relook and think about it, if we do our audits, we'll find that most of the citizens that we've lost to were comorbid. And if we analyze the causes of comorbidity, it will boil down to, these lifestyle diseases, which very often, we take lightly and we do not talk about it so much. It is glamorous to talk about it. It doesn't garner the kind of attention it should have. But now it has changed. Similarly, the health-seeking behavior of the people have also changed. Now, because of the post-COVID complications, also people are now more concerned. Now they are more concerned about, I would say, each and every organ of their body. Earlier, it was taken very lightly because, these kinds of lifestyle diseases require a lot of iterations. There's a lot of do's and don'ts. It's not just about taking a pill every day. It's also about altering your lifestyle, and that's where the concept of wellness, concept of prevention also comes in. So I would say there has been a paradigm shift. There has been, change of focus, both from the policymakers' point of view and also as demand from the public. So it is coming. I would say it's a positive change on both ends, and so there is definitely a need to, revisit and relook at how we frame our policies and how we want to cater to the needs of the new demands of the people. And lastly, we should always also bear in mind that we have to have some room for the new technological innovations and the new products that keep coming into the market. They may be good, they may be cosmetic, they may be bad, but there has to be some room for it to test and pilot, and then decide for ourselves whether we want to use this particular product for proactive screening or it is not required, and whether our budget permits it or it does not permit. But at the end of the day, when we're talking about health and we're talking about health for all, we have to keep our minds open to innovation, to a lot of cross learning, and to a lot of thought from all corners of the world.
Thank you very much, ma'am. I think brilliant points that you brought up, as well as the need for assessment of technology from time to time, which will then make the output make sense of the output as far as the patient is concerned, because the individual is at the core and the center of this entire part. So my last question, ma'am, to you, Dr. Rajprabha, you mentioned mental health, right? And I think if anything COVID has brought for, it's like saying it used to be the elephant in the room, but now everywhere in all spheres, people are taking hesitant but very positive steps as far as mental health is concerned. I don't know how far we'll be able to go and what time frame where this entire piece will be spoken of in as normal and we don't have any hesitancy. But given the levels of literacy, as you mentioned earlier, suicide rates, so what would your comments be on addressing mental health, and perhaps if you could share something that the government of Sikkim is doing in this, please. Over to you.
Regarding this mental health, I think now with so much of digitalization, everything is fast, pace. It is moving at a very fast pace. Like initially, when we did not have this internet service or anything, then everything was, we used to get letters from the ministry, then we process the file, then you have time, to, put up the file and then do the activity. So I think that was in a way very, when I look back, it was when I was in the PHC, we used to have these, what you call the wireless telegram. We did not even have a telephone in the PHC. So our life was very, very different. But now with this, digitalization, with WhatsApp, with like video conference or anything, everything is instant. So with this, the pressure, what I saw during the COVID time, the students also, these online classes, everything was through online, through the internet, and we have so much of knowledge, or what to say, information that is being thrown towards us, even children, adults also, from the internet. So the amount of knowledge that we have to take in and to process it and to do activities is huge compared to what it was before. So I think that on itself, we have, really jumped into a new, as ma'am was saying, a new paradigm level of, our lifestyle. So that is one thing. Then we have this, what you call that? So a lot of things, the competition is high. So similar in the rest of the country, like that only in Sikkim also we have this problem. The competition that is there amongst the students, Then another thing is what I feel is it may be, something related like a relative misery sort of thing. When we have quick development, what has happened in Sikkim also, we have had a lot of developments, whether it is through tourism, through economically, there has been a lot of developments. So maybe that, when you try to have you compare yourself with others, or maybe that may be also another factor causing this high societal rate amongst the children. Because recently we had a very small child, age around 12 years, committing suicide, which is something we need to really think about. So what we have done is we have had many meetings, not only with the health staff, but with students. And we have these, wherever it happened in those schools, also we had meetings, and then also in the community, then also with the police department and education department, we are having convergence programs. Then we have this 24/7, this helpline, crisis helpline. So anybody, in fact, it is there in the net. So anyone from rest of the country also can call. Even we get calls from the rest of the country also. So that is there, and then we also have counselors. We already have these counselors placed in the primary health centers, in the districts, and even in STNM, who do counseling. Their basic work is counseling. But we are also not only targeting the adolescents, but we are also targeting the antenatal mothers. We are trying to expand the counseling service. Even in the antenatal, clinics outside, we are trying to have group counseling, because, other things can be addressed also at the same time. So that is how we are trying to do. But this, mental health and suicidal tendency is such a, it is a very, sensitive subject, that we need to go in a very, you have to walk, I think, softly, or whatever you say. Because when we try to talk about suicide, it might, in fact, instigate somebody to do a similar act. So that is why we are working with NIMHANS. We have the SPAN project, which is running, and we are trying to find out the causes, why it is happening also. So that is how we are having school programs in the community, then also with interdepartmental, and we have the crisis helpline. That is how we are trying to, address the mental health problems that is happening.
Brilliant. So I think we will be coming to the end, and I can't help but saying there's kudos to women power, considering we have Khushbu also there. And as an individual, as a citizen, I think it's this particular part in our lives has been extremely heartening to be able to see that there not only there is commitment, but people like yourselves are taking this movement ahead, addressing the challenges headlong, as well as embracing the digital technology, which I believe will be a very powerful spine to the entire piece of healthcare delivery. Having said that, the challenges of keeping up, as you very rightly pointed out, both of you in your own ways, that things are evolving so fast that expectations have to be met. And when expectations have to be met, it would require repeated introspection and tweaking along in the journey. So there'll be a degree of patience which will be required on both ends, both from the provider perspective, as well as from the service, from the individuals themselves. So all in all, it seems good days are here, and we collectively as people will be able to manage it with your very firm leadership. Thank you all so very much for being here and sharing your insights. Back to you, Khushbu. And thank you, Voice of Healthcare, which always is able to put us together to have a meaningful conversation and dialogue. Very warm welcome to Dr. Ajit Mohanty on the topic of universal health. I think, as we all know, universal health coverage and being able to access healthcare when we need it is one of the most important things in an individual's life. We are extremely fortunate to have with us today to discuss in depth and detail about the scheme with Dr. 𝗙𝗖𝗡𝗄𝗡𝗅𝗏, who is Special Secretary, Department of Health and Family Welfare, Government of Orissa. Welcome, sir, to this webinar.
Namaskar, madam. Good afternoon to all. Myself, Dr. 𝗙𝗖𝗡𝗄𝗡𝗅𝗏. Madam, I would like to introduce myself as the Special Secretary Health to Health and Epidemiology Department. Madam, regarding the universal health coverage, madam, is there any specific question or should I start of my own?
Sir, the floor is all yours. In fact, we would be very, very keen to know how you are being able to cover the entire population, because whatever little that we've heard of the universal health coverage, it was sectorial by nature. But in Orissa, you have been able to cover the entire state. So all over to you, sir, if you could brief us. And then if there are any questions, anything that is left we need to know in detail, I'll request you, sir. Over to you.
Thank you, ma'am. Actually, madam, about the universal health coverage, in our state, we have got our Biju Swasthya Kalyan Yojana, or BSKY scheme. The aim is to provide the universal health coverage, and we give a special emphasis on the protection of the vulnerable families and the women's health. Madam, in this universal health BSKY or universal health program, the vision of our Honorable Chief Minister is there should be every life is precious. So nobody should be allowed to not have the best possible health facility in our state, irrespective of their caste, creed, and economical status. So in this regard, madam, BSKY scheme was introduced in 2017. And now in that scheme, actually we have got two components. One is cashless healthcare services in all the state government hospitals. In all the state government health facilities means it starts from the sub-center, health and wellness center, primary health center, CSC, sub-division hospital, district headquarters hospital, and all the medical colleges and tertiary care centers. In all those health facilities, everything is free, and the government ensures that the out-of-pocket expenditures is zero. Regarding the investigations, all the investigations are in the PhD level. Around 20 investigations are done by their own laboratory technicians. In the district headquarters level, they do around 70. I don't remember exact the figure, but still we have got certain high-end pathological investigations which we do by our outsourcing pathologists. So we have got outsourcing facilities in all the district headquarters hospital and the CSC and STH as far as the radiological diagnosis like CT, MRI are concerned. In the district, we try to provide now digital X-ray in almost all the CSCs and the semi-auto analyzer in all the CSCs. And our government has provided CT scan in all the district headquarters hospitals. And the MRI scan is limited to only our 11 government medical colleges besides the other private medical colleges. In all the facilities, all the investigations are free of cost to the people. So it is run by the PPP mode, and the amount is reimbursed by the NHM. So regarding the delivery of the medicines, madam, we have got our Niramaya scheme where we provide all the medicines. Even in our all the district headquarters hospital and some of the STH and few CSCs, we have got our district daycare cancer chemotherapy. There also we provide all the chemotherapy, all those anti-cancerous drugs free of cost to all the patients. So we ensure that it is even the costly medicines are given by the government free of cost under the Niramaya scheme. Similarly, the various investigation that I was telling, it is covered under a Nidan scheme. That is all the pathological investigations and all the radiological investigations where it is not possible to do it in-house, so they outsource it to the private agencies. And regarding the component 2, it's a cashless healthcare system in the empaneled hospital. And about the empanelment of the hospital, we have got 500 empaneled hospitals, 402 in our state, and 98 hospitals in across the India in 17 states. And it covers almost all the referral hospitals like Apollo Group of Hospital, Narayan Hrudayalaya, Medanta Hospital, and all the big hospitals are covered under this BSKY scheme 2. So where in the BSKY scheme 2, madam, we cover about 96.5 lakhs families, which covers around 3.30 crores of the population. Now in our state, we have got 4.5 crores population at present. So under this BSKY scheme, we cover BSKY 2 scheme. We cover all these 96.5 lakhs families, and that is around 3.3 crores people. The people under this scheme, they get benefit under BSKY scheme in the referral hospitals outside the state, and also the various referral hospitals inside the state, all those 500 hospitals. And in this BSKY scheme, around there are 2,056 packages that cover, those are covered under this scheme, and those are also at competitive rates, so that the hospital who run this BSKY scheme, they will not be at a significant loss. Similarly, the annual health coverage is, it is 5 lakhs per family per year, with an additional amount of 5 lakhs per family per year for a female member of the family. And similarly, the higher package rate are also given to the various hospitals, those who have got the NABH accreditation. And in all the BSKY hospitals, we provide the Swasthya Mitra. The Swasthya Mitras are deployed. So they facilitate all the poor and illiterate people from the rural areas, particularly from the rural areas. They facilitate starting from the entering the patient into that hospital till they are discharged from that institution. So we provide Swasthya Mitras in all the hospitals. Even in the outside our state, those like Hyderabad Hospital or Visakhapatnam or Delhi, we have got our Swasthya Mitras placed in all those hospitals. They take care of this, particularly these illiterate and innocent patients, lest they will be exploited by all those people. Similarly, madam, 100% cashback to all the BSKY deliveries. And in our empanel hospital, about 75% of the beds are supported under this BSKY scheme. So most of the hospitals, they capture these BSKY patients. They usually they are not the sufferers, they are not the losers. Madam, they get all the benefit. Similarly, if we consider the bulk of the benefits, madam, outside our state, we provide every month around 5,000 patients, benefit to around 5,000 patients. And also daily, about every day, we provide around 2,500 BSKY patients in our state. Cashless services amount to 5.5 crores per day. So under this BSKY scheme, not only most of the things like from the diagnosis, from the from the treatment, from the follow-up, from the medicines, everything is, madam, covered under this BSKY scheme. So that is done with a vision of our Chief Minister to like the every life is precious. So, madam, these are some of the important features of the BSKY scheme, which is a health assurance scheme. Particularly, it's specific to our state. So, madam, we are not audible. Madam, you are not audible.
I said it's absolutely outstanding what you have shared with us, and I'm sure our viewers will equally share the same sentiment that you've covered 3/4 of the entire state, and they have the flexibility that if anything is not available, they can go to other states. And I think this concept of the Swasthya Mitra, which you very rightly pointed out, is a very critical part of being able to handhold people who are not literate. It's even, I mean, health literacy is not common to most people, and it's not only the poor, even the educated people don't know what questions to ask. So, sir, this brings
Madam, one point I would like to add here, Madam.
Please.
Yeah, under this BSK scheme also, we provide the shelter for these rural and innocent people in some of the states like Visakhapatnam, like Hyderabad. We have got our district specific Madam. So guest rooms where these persons are given shelter almost at a very minimal rate, at a subsidized rate. That also it is being provided by the government.
You're brilliant. You were thinking in my mind, because exactly that was going to be my question, that within the state, people will find relatives or somebody to stay with. But when they go out of the state, how are they going to be supported to be able to stay in that state? That becomes a challenge. But you answered it yourself and said that we have these guest rooms, which is extremely laudable. So from what we have understood from other states is that 40% of the money is provided by the center and the rest of it is balanced out by the state. Given the huge outlay that is there for this scheme, and you're covering them up to 5 lakhs, can you also just share with us as to the uptake of the scheme? That is, are you able to balance whatever you have budgeted with the demand of utilization so far, Dr. Mohanty? Over to you, sir.
About the 60-40 scheme, mostly this is those schemes which are sponsored by the NHM, National Health Mission. Those in those cases, 40-60 program is implemented. But madam, in other programs like our those NHM sponsored schemes are like Nidan, Niramaya, and this high-end pathology, those are covered under the NHM scheme. And now others are the BSK scheme is totally it's a state-specific scheme. So the fund is totally provided by the government of Odisha. And for example, in the last few years, the total budget has gone double up. Previously, it was 600 crores. Now it is above. In 2019, it was around 650 crores. Now it has gone beyond 1200 crores. So similarly, the drug purchase under the Niramaya scheme also, it has gone to more than 3 times.
That was my question, because as people get to know about the scheme, the utilization pattern will go up high. In the long run, will you be able?
Go to? সেটা ঘরে দিয়ে দিও তলে it's a call.
Not to worry, sir.
Sorry.
So my question, sir, was that as people get to know about the scheme and how wonderful it is, the utilization pattern will increase. One thing is when you cannot access anything, the utilization is not there. But when the state is so brilliantly supporting the program, more and more people the uptake will be higher. So will, in the long term, the state be able to support the increased utilization pattern, sir?
Madam, actually, this question is really, madam, this is a problem. Initially, the government, 3 years back, the people for the BSK2, to get all the facilities under the BSK2, they used to provide the income certificate from the competent authority. Now it is everything is they do not have to show any document. Now this BSK2 smart card, it's a chip-based card, and where all the data of the families covered under this BSK scheme, their data are incorporated. And also, in case any person who doesn't remember, who doesn't carry the card, if he remembers that number, like our Aadhaar system, it is linked to the Aadhaar, and it is linked to the Aadhaar card. So if you remember this number also, you can get the benefit. And regarding the sustenance of our state, now it is our policy in the newer health policy. The government is increasing the scope of this BSK scheme. It is now covering almost all the Now we are planning to cover almost all the entire population. Now in our state, up to the from the sub center up to the medical college and up to the cancer care center and all the tertiary facility, it is free. But still, we about these people who are not able to get the proper care and they are going to outside. Now government is taking care to have more NABH accreditation hospital and super specialty center in our state. Our government has floated a tender for the affordable healthcare where we are going to create 4 super specialty hospital in our state, and also we are planning to have some more medical colleges and also cardiac care, cancer care, dedicated cardiac care and cancer care center in our state. Here only these tertiary facilities and all the radiotherapy, chemotherapy and all those things, they will be addressed inside our state so that the people may not have to go outside.
You mentioned the health smart card, sir.
Yes,
so very clearly, there must be a very strong digital backbone to your entire system. When you're seeing such a large population, the health smart cards are there. Do you also track the outcomes of all of this? Are there any specific metrics that have improved ever since the institution of this scheme has been there, which perhaps addresses the SDG goals or something like that? Are there any KPIs that you could share with us which have been impacted?
Madam, as I told you, it's a chip-based smart card. In April, we have got a BSK cell in our directorate. So they used to monitor, they used to review all the expenditure and all the health facilities those people they are getting outside our state and also inside our state. And also we try to get the patient satisfaction index. So this, not only the BSK card, we reviewed regularly. If there is any complaint from the person who is going to get the treatment outside the state, or even if inside our state from the different private hospitals or nursing home, we used to get their feedback so that we can will able to improve the services under this BSK card. During the survey also, we can have direct review and we can have a direct picture in our BSK Panel Hospital, how many patients are getting treatment and how many patients are getting the treatment under which scheme, under which package, and whether this package they are getting the benefit properly. And even we ensure that all the hospitals they used to get the reimbursement by within 15 days, maximum by 21 days. Right. So feedback from the patients and also feedback from the hospitals, those are taken into consideration for improvement in the next phase.
Perfect. So, repeatedly what has been said also is that there is a chronic shortage of healthcare professionals, right? Across doctors, nurses, paramedics, etc. Has the state ever considered having a medical cadre for Orissa for them, or do you already have it? Do you have a healthcare cadre?
No, madam. We are in the government system. We have got our healthcare cadre, madam. As you rightly pointed out, there is a definitely dearth of medical professionals in our state also. In our state, so the government in the recent last 3 years, madam, in the last this year only, we have got 2 medical colleges functional. Admission, MBBS admission has occurred in this July and August. And previously, in the last 5 years, we opened around 4 medical colleges. Previously, madam, 10 years back, we had only 3 medical colleges. Now we have got 11 medical colleges with 1 postgraduate institute. So, madam, government in the newer health policy, government tried to ensure that all the health facilities should be saturated by 2023 December with at least MBBS doctor. We may not provide the specialist or the super specialist, but all the health facility will be saturated by MBBS doctors. And we will make all the health and wellness center functional even at the remotest area of our state.
That's fantastic. Absolutely fantastic. When you mentioned the health and wellness centers, On
Yes.
the aspect of preventive health, sir, how are you approaching that? Because, like you said, you had these fast mitras for these patients. On the preventive aspect, is any other scheme or any thought process you would like to share with us as to what the state of Odisha is doing?
No, in our health and wellness center, now all the health and most of the health and wellness centers are saturated with the CHO, Community Health Officer. We give training, 6 month training to the staff nurses who are there in the concerned CSE. So she is appointed there as the community health officer. And in the health and wellness center, madam, we run the doctor, MBBS doctor is there, and one Ayurvedic doctor is there. Madam, there also we undertake all the preventive measures, all the RMNCS plus all the activities are going on in the health and wellness center. Besides that also, there is a yoga class, there is a yoga teacher who used to come twice a week. Usually, though they come on the part-time basis, they are the part-time yoga specialist. And also the other public health activities, those are going on in the health and wellness center. And now regarding the particular emphasis is given in the health and wellness center about the NCD, non-communicable diseases. We are planning to have a NCD database in our state. We have started our NCD screening, and also we are incorporating all the data from starting from the health and wellness center level. And they used to first they screen the patient, and if they suspect any case, they get all these patients examined in the nearest CSE, and if they found to be positive, then we enter into our database. And we ensure that in all the cases, the patient may not able to go to the district hospital or the medical colleges. But once the diagnosis is confirmed and all the investigations are done in the district hospital or in the medical college, madam, we ensure that all the medicines you should get from the health and wellness center itself. That we try to ensure. And also, madam, particularly it was very effective in this COVID pandemic, madam. Those patients who are chronic patients like, madam, those psychiatric patients under the mental health scheme, and also the diabetic patients and hypertensive patients. Because at the time, the people are not going to outside. In those cases, we used to provide the medicines through our ASHAs from the health and wellness center at their doorstep.
Fantastic. So it must have been a logistical challenge to be able to do that, to go to the doorstep. It's a huge task. And this must be done through the district collector's office. So yes, there were some PPPs in this.
The collector was overall in charge of all this program, but mainly our CTM and PHO and district public health officer, they used to ensure the smooth functioning of the health and wellness sector.
It's truly heartening to hear all of this. I'll just ask you one more question, sir, and then if there is anything else you would like to share with us. So there's been a lot of talk, especially after post-COVID, on mental health, sir. So do you run any kind of services for mental health, counseling and things like that? Over to you, sir.
Actually, madam, mental health, we have got our state mental health authority in the Center of Excellence, that is in SC Medical College, Kotak. In all the 30 districts, we have got district mental health cell, and the district mental health program is continuing there. In all the district headquarter hospital, we have got a mobile mental health unit. In case of any, we have got also one dedicated ambulance for this mental health scheme. Now, suppose in case we get any information about the underage lunatics or a particularly a lunatic, he is being tortured by the relative or home, or he is moving in the street or railway station or in the bus stand, we used to go and pick up if there is any if any guardians or relatives are there, we used to get the permission and we maintain all the official formalities, all the legal formalities. We try to keep them in the mental in our centers, in rehabilitation center. Similarly, also in the district level, we have got certain halfway homes, and particularly these under this district mental health program, we also cover the de-addiction center, DAC, madam. So the DAC is mostly being looked after by the SSCPD department. And the mental health program, these under this halfway home and all the maintenance of these persons with acute psychiatric problem, those are handled by our health department, madam. So in 4 districts, we have got dedicated DSA and the mental health sanatorium or the mental health ward, 50 bedded mental health institution. So there we keep them. And also, it's a practical problem that after the patient is cured, many times their relatives, they are not willing to take back the patients to their family. So that's a real challenge. In those cases, we keep them in halfway home. We do the counseling, not only counseling of the patient, but also counseling of their relatives, of their home members, of the son, daughter-in-law, those things. Then after counseling, we used to send the patient. And we follow it up.
Fantastic. So last question, sir. On the aspect of nutrition, especially for children, adolescents, as well as TB patients, are there any thoughts you'd like to share with us as to what is being done for the nutritional status of the population as a whole?
Madam, as far as the tuberculosis patients are concerned, the Government of India scheme 𝗙𝗂𝗡𝗅𝗡 is going on. We ensure that the patient get the benefit through DBT. And regarding the maternal health, those antenatal cases, we give them take-home ration for every week. We used to give them the calculating their protein necessity, and also we provide the health and our health department, health and family welfare department. We used to give them 𝗙𝗓𝗡 tablet, calcium tablet. At the same time, also, madam, we ensure that she gets the take-home ration from the WCD department. So that at least, it's a fact that if she takes take-home ration 2 kg, hardly half kg will be her share. So in a joint family, and particularly those the poor families, usually their children, they used to eat up all those, most of the rations. But still, whatever it may be, let her get 10% of the share so that some benefit will be going to that person. And madam, this regarding the nutrition of the patient, we in our rural areas we have got a VHND where the nutrition status of the patients, nutrition status of this pediatric age group, particularly preschool going children, they are monitored regularly. And in case of any nutritionally deficient patient, we used to send them to NRC, Nutritional Rehabilitation Center. And about the infants and neonates, we provide them with vitamin A supplementation, iron drop supplementation. And the adolescent people under the NIPI program, weekly iron supplementation program, we used to provide them through the school science teachers, and also in those people who are not going to the school, particularly adolescent school dropouts, we used to provide them through the ASHA.
Excellent. Sir, it's been such a pleasure talking to you, and compliments to the entire state of Orissa for a fantastic job. I know it's a humongous problem, which is just going to increase with time, and especially with post-COVID throwing up its own challenges. But our best wishes, and again, once again, a fantastic job done. And thank you so much for spending time together.
It's only possible with the help of our administration and with the help of the Government of India and you people all, madam. Thank you.
Thank you. Thank you so much. Thank you, sir.
Namaskar. I'm Dr. 𝗙𝗂𝗡𝗅𝗏𝗔𝗟𝗬, Director, Directorate of Health Services, Goa. The government of Goa is committed to giving equitable, affordable, accessible, and high-quality health care through its several primary, community, urban health centers, as also the sub-district hospital, the district hospital, and the tertiary care hospitals. Wherever specialist care is required, besides the tertiary care hospitals and the district hospitals, care can also be provided through the private hospitals through the various schemes of the government of Goa. I will be presenting a brief on the schemes which are given by the government of Goa to residents of Goa. Firstly, the 𝗙𝗘𝗧𝗨𝗏𝗂𝗑𝗧𝗏 has been rolled out in the state in effect from 1st September 2016. The scheme provides health coverage to the entire resident population of the state who reside in Goa for 5 years and more. The benefits under this scheme is, it is provided on a cashless basis to the beneficiaries up to the limit of their annual coverage, providing coverage up to 2.5 lakhs per annum for a family of 3 or less, and coverage of 4 lakhs for a family of 4 or more members. The insurance benefits can be availed individually or collectively by the members of the family. Presently, the DDSSY scheme is being run departmentally through a TPA, India Health Insurance Private Limited. A total of 447 medical procedures are covered under the scheme. A total of 39 private hospitals and 8 government hospitals in the state of Goa and 13 private hospitals outside Goa have been empaneled. The total active cards for the policy year 2022-23 till date is 2,94,264 and 13,983 number of beneficiaries have taken benefit of the scheme. The total corpus received is 30 crores 4,80,289 during the current financial year and 29 crores 98 lakhs 98,978 is utilized for the claims settled. The Ayushman Bharat Pradhan Mantri Jan Arogya scheme is also operative in the state of Goa. It is a flagship scheme of the Honorable Prime Minister of India, which was launched in the state of Goa on 23rd September 2018 along with the national launch. 36,431 families are eligible for the ABPMJY in the state of Goa, of which 9,738 families comprising of 26,323 individuals are registered as on 30th November 2022. Till date, 22 public and 14 private hospitals are empaneled under the scheme. The objective of the ABPMJY is to reduce catastrophic health expenditure, improve access to quality health care, and reduce the unmet needs and reduce out-of-pocket healthcare expenditures of the poor and vulnerable families of the socio-economic caste census database of the state. It provides a cover of 5 lakhs per family per year for secondary and tertiary care hospitalization across public and private empaneled hospitals in India. There is no restriction on the family size, age or gender. PMJY has 1,652 medical packages in Goa for covering surgery, medical, also day care treatment. The benefits of the scheme are, it is portable across the country. That is, a beneficiary can visit any empaneled public or private hospital in India to avail of this cashless treatment. We have another scheme, which is the Goa Mediclaim scheme, which was introduced in Goa in the year 1989, wherein financial assistance is provided under the Mediclaim scheme to every permanent resident of the state of Goa for availing super specialty treatment that is not available in the government hospitals in the state of Goa. The eligibility criteria as per the scheme is, person should be a permanent resident of Goa for the last 15 years and has to figure in the voter list and has to hold a permanent ration card. The family income should be less than 1.5 lakhs per annum, and for such facilities which are not available in the government hospitals, including Goa Medical College, Bambolim and district hospitals, the benefits of this scheme are provided. For newborn intensive care unit, ventilatory support and kidney dialysis patients, they may opt for any empaneled hospital even if the facilities are available in the government hospital. The hospital should be recognized under the Mediclaim scheme. Retired state government employees shall also be entitled for the scheme. They are exempted from the monetary income ceiling. During the current financial year, till date, an expenditure amounting to 78.18 lakhs has been incurred. We have another flagship project, which is STEMI Goa project. It is a Government of Goa initiative by the Directorate of Health Services, started in the year 2018 with an effort to reduce the myocardial infarction or the heart attack cases in the state of Goa. It is run on a hub and spoke model. There are 20 spokes and 4 hubs which provide thrombolysis at the PHC level, followed by transfer of such patients to the nearest hub with the help of specialized cardiac EMRI ambulances. Till September 2022, around 2,201 patients have been thrombolized in the periphery under this project. We also have a changing diabetes barometer project Goa. We have taken into cognizance of the increase in the number of non-communicable diseases, especially diabetes, which has long-term effects on the patient's health, and we have undertaken this project. The government of Goa is committed to halt the rise of diabetes in Goa and believe that timely detection and treatment can help people with diabetes lead a healthy and complication-free life. Keeping this in mind, the Changing Diabetes Barometer project was launched in the year 2018. Under this project, free insulin is provided to all the patients as well as oral anti-diabetic drugs at the peripheral health centers, and 15 diabetic educators are appointed to provide counseling on diet, exercise, and importance of compliance to medication. All these are reviewed periodically. Till September 2022, 1,60,797 diabetic patients have been counseled by the diabetes educators. Ayushman Bharat Health and Wellness Centers is another approach to deliver comprehensive range of services spanning from preventive, promotive, curative, rehabilitative, and palliative care services. Also, health and wellness centers are envisaged to deliver expanded range services that go beyond maternal and child health care services to include care for other non-communicable diseases, palliative as well as rehabilitative care, oral eye ENT care, mental health, and first level care for emergencies and trauma, including free essential drug diagnostic services, are all provided under this. In the existing sub-health centers, the primary health centers are being transformed as Ayushman Bharat Health and Wellness Centers. The cumulative health and wellness centers operationalized in the state of Goa for the year 22-23 are 201, of which 24 are PHCs, 30 are rural medical dispensaries, 4 are urban health centers, plus 1 UHTC, plus 1 RHTC, plus 141 sub-centers. We have another flagship project, which is the Swasth Mahila Swasth Goa project. This project was launched by Government of Goa in partnership with 𝗖𝗎𝗄 Singh Foundation and SBI in the year 2021 to screen a targeted population of 2 lakh women in Goa for a period of 2 years using the iBreast device. Till September 2022, a total of 38,913 beneficiaries are screened for breast cancer, of which 16 cases of breast cancer have been detected and confirmed and are undergoing treatment. We also have the Pradhan Mantri National Dialysis Program. Under this, in partnership with Apex Kidney Care Private Limited, hemodialysis services are provided under public-private partnership at 14 health facilities under the DHS Goa. For the year 22-23, around 14 dialysis centers and 118 functional dialysis machines have been implemented, and 57,329 dialysis sessions were conducted till date. These are some of the ways in which we ensure that universal health coverage is provided to all the residents in the state of Goa. Thank you.
A very good morning and welcome everyone. I, 𝗙𝗎 Gupta, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of Universal Health Coverage Day, Voice of Healthcare has taken an initiative to bring together the experts and the speakers for this resourceful discussion today. In this discussion, our speakers will talk about how to build health systems resilience for universal health coverage, emergency preparedness, health security, and uphold care quality. I would like to commence this session by introducing our eminent speakers. So, for today's discussion, we have Ms. Upasana Arora ma'am. She is a director at Yasoda Super Speciality Hospitals, Delhi NCR. Welcome, Ms. Arora. We have Dr. Amnil Rapport. Sir is a managing director and group CEO at Narayana Health. Welcome, Dr. Rapport. We have Mr. Neeraj Lal. Sir is the Chief Operating Officer of Gujarat region at Apollo Hospitals. Welcome, Mr. Lal.
Very good morning.
We have Dr. Geetika Madan Patel. Ma'am is a trustee and managing director at Parul Savesaram Hospital. Welcome, Dr. Patel.
Thank you. Good morning.
We have Dr. 𝗙𝗖𝗔𝗘𝗓𝗔𝗍𝗘. Sir is a Director General at Association of Healthcare Providers India. Welcome, Dr. Gyani. Along with sharing his views, Dr. Gyani will also be moderating today's session. So without further delay, I would like Dr. Gyani to lead this session. Over to you, sir.
Thank you very much. So I think the agenda is very focused. Universal health coverage is the talk of the town these days, not only in India, but world over. Every democracy wants the population to be covered for the healthcare. They try to do it free of cost. Some of them, they try it in a graded manner. That is a below poverty line population gets the free access. And as you go up and up, they get some subsidized healthcare. So that is a model. The two major, schemes. One is the Ayushman Bharat, under which 500 million population, that is 40% of the Indian population, is expected to be covered for the healthcare under the PMJY, they call it, with the 5 lakhs rupees of insurance for per family. Another scheme which they have launched 2 years later is the National Digital Health Mission, which they have also renamed as Ayushman Bharat Digital Health Mission. So combining these two, we expect that they will be, they will change over the scenario of the healthcare in our country. But of course, that is going to take about 3 to 5 years' time as per the government estimate. So let me just give you a little bit of statistics and then we will start the discussion. That today we have got 1.7 beds per 1,000 population, and the government's target is keeping in with the WHO, norms, 3.5 beds per 1,000. That means what is expected is that we have to more than double the number of beds in the country in time to come. Second requirement, which was pointed out by WHO report, was that India is very poor on accessibility. They have tried to, concentrate the hospitals mostly in tier 1 towns and some in tier 2. Tier 3 is left without any tertiary care cover. And other aspect which government is now very conscious about it, that 85% of tertiary care beds are with the private sector. So that means there is no other way but public and private sector has to join to deliver the universal health coverage under the Ayushman Bharat. As far as doctors are concerned, we have around 13 lakhs registered doctors, but 30% or maybe nearly 40% of them are MBBS, and that means we still have huge shortage, and that comes to about 0.75 per 1,000, which we need one. So doctor means actually he has to be, by and large, I will say, I don't want to put it that he has to be only a specialist, but by and large, that is a fact. So that is also we have shortage. So all in all, the National Digital Health Mission is being launched aggressively. The scheme of Ayushman Bharat can go progress. So this is actually the plan of the government of India. So I think this is a very good discussion point today, that how we, India and private sector, can join hands with the government to meet the ambition of entire population covered under the healthcare. And let me remind here, last line, that universal health coverage doesn't mean free healthcare. It means providing healthcare to the population at the cost which they can afford. I think this point, in my opinion, I'm very frank here, is still not understood by the government. Politically, they feel that we should target to provide free healthcare services, for which, unfortunately, they do not have the resources, with the 1.35% of GDP being spent by them. So this is one limitation. And to open up the discussion, last line will be the universal health coverage comprises of the 4 segments: availability in terms of doctors and the beds, accessibility, that means uniformly the healthcare is available everywhere, affordability, cost at which the people can afford, and last one is the acceptability, that is the quality patient. So these 4 A's complete coverage. So with that, I open up the discussion, and in fact, I can see Dr. Rupert, Pasna, Dr. Geetika, Neeraj, I think all of them have excellent track record in their own areas. But I will begin with Neeraj Lal. And the question is very simple, that the Ayushman Bharat or the PMJY is now in operating since 2018. That means 4 years are complete. And this is basically operating through PPP. Because why I'm saying PPP? Because government is buying healthcare from the private sector, more so for the tertiary care. So can you tell us how it has transformed the PPP model in India, and how you think it should be altered in the future to make the impact? So that second question is about what recommendation you are going to make to the government.
Right, sir. Sir, you are very right about this APPMGY. This was launched few years ago. I think firstly, main aim of the government is to empanel more and more hospitals. And we are seeing many hospitals become a part of this. But I think now most of the hospital private setup is a part of this scheme, but real problem started now. See, like say, for example, in government of Gujarat, we were one of the few hospital among there where we are taking care of PMJY patients. But again, the same story. It is just like a CGHS empanelment, and you are providing services. They have empaneled with the private insurance, and the issues remain same. However, few things. What I feel, I think healthcare strategy with public and private partnership is not weaving together, sir. I'll give you one example to support my statement. In Ahmedabad, there is 1,200 bedded a hospital which is known as Sardar Patel Hospital. Sir, it is right on Sabarmati riverfront, and it is catering a huge amount of population. You can compare this hospital with any big corporate hospital in the country. They have vertical and horizontal conveyor belt. They have one of the best doctors. They have Apollo Sunduri as their F&B partners and whatnot. But this is a perfect public-private partnership. But here, if you see, the public-private partnership is limited for extension of PMJY scheme to the private hospitals. So that is not happening very well. So pre-hospitalization, post-hospitalization, things are not very good. Even most of the hospital, like one day, most of the private hospital have went to Gandhinagar to stop their scheme because their outstanding was close to 750 crores. So I think private hospitals, which is contributing around 77% of the total healthcare, if government is just looking to just empanel the hospital and giving the services, that is not happening. Few days back, government of Gujarat has empaneled some of the private body for the health checkup of their employees. And this scheme is happening very well. So I think government is very selective in these things, like school health program, which a government of Gujarat has. So all the district of Gujarat, you screen the children's, take them to UN Mehta Institute of Cardiology. That scheme is not extended to the government hospitals, to the private hospital. So the scheme is not wholesome. Sir, one of the best program which I came to know in Gujarat is school health. Or if you see the waiting list of these school health children for a cardiac problem, it is 3 to 6 months. But this is the selective part of government of Gujarat. For PMJY, they want a private hospital to come on the same panel, but for all these schemes, they're not. So I think wholesome coverage is not there. I always feel they are also not using the real strength of private healthcare. Technological advancement is there, capacity building is there. Sir, augmenting supply chain management. I think private hospital have got one of the wonderful supply chain management, but I think it is not seen in the government hospital. They've got one of the best equipment, one of the best doctor, but I think their stores, their pharmacies, their cardiac cath lab, and so on does not have an efficient supply chain management. They are not using digital health. People are still traveling far off places to come to a government hospital. On the contrary, private hospital has adopted digital health to a great extent, and now I think 30% of the patient we are seeing on a virtual consultation. So I think if these things government can take in a true public-private partnership, we can able to extend this comprehensive health checkup to the patient, and a good mix can be done between public and private. The government is looking one side of the coin, not another. That's all my feeling is, sir.
Okay. I think I got your point, and maybe a supplementary question is required. I will again come back to you. But
Yes,
now
sir.
let me turn to Dr. Rupert. Now, to Dr. Rupert, I'll put it in a different way. Irrespective of PMJY, whether Ayushman Bharat is there or not, the Narayan Health got branded that this is the group which provides the affordable healthcare services to the population. Now, that time, of course, has changed. Scenario has changed. I want to know from Dr. Rupert how actually do you continue to provide the healthcare delivery to the weaker socio-economic people, and how is this model working? If it is working today, how it is working? I think others would like to know from you. Dr. Rupert.
Good morning, Dr. Gyani. It's a very good question. We have been working with the various state governments and this national government for a long time. And we have worked predominantly in the areas of cardiac sciences, and for the last 8-9 years, we have also been working in the areas of oncology. And cardiac sciences has been a passion, and we have especially done a lot of work in the pediatric cardiac sciences over the years, partnering with various agencies and the government schemes. To this day, we treat more than 20,000 patients as inpatients across the entire network, and almost close to 100,000 patients in the outpatients from the weaker sections of the population through various programs which we partner with various organizations. And predominantly, these have all been in the areas of pediatric cardiac sciences as well as the oncology, bone marrow transplant, and we have limited ourselves to tertiary and the quaternary care. We do approximately around 8,000 pediatric cardiac sciences procedures per year. And this is a large sum of amount which we are doing. Is mainly the high-end, the very high-risk patients, but most of it is also 70 or 80% of them comes through partnership with the government or various other organizations. We've also been doing a lot of free COVID vaccinations for the poorer sections and the weaker sections of the society. About 5% of our revenues have been written off at discounts for the weaker sections, which a team of medical social workers assesses them, and genuinely they feel they are in a difficult state, and a lot of things have been written off as far as the discounts are concerned. We have a dedicated medical social working group called as the Guest Support Cell, which looks at all the patients' need for additional funds and provides for that either internally or through partnership with various other philanthropic organizations. And we have been able to do very high-end work, including bone marrow transplant in many of our centers because of this kind of unique program which we have been able to do. We have also been doing a lot of outreach camps for screening, which is very, very important. Just like Mr. Lal had mentioned about the school health program in Gujarat, we have been working with various state governments to have a primary and a secondary level screening camps for congenital heart diseases, as well as we've also been doing for thalassaemic patients through the Thalassemia Society, a lot of HLA screening camps, HLA typing so that they'll be prepared for a bone marrow transplant through some of our centers, and also through various other centers, whoever are willing to undergo these things. We've been screening, the rural population and the lower socioeconomic status in the urban areas as well for preventive oncology, especially in the women's health issues of breast oncology and the gynae oncology. And also we've been working a lot on the head and neck oncology through a lot of AI-based technology, which have all come into the place. But apart from this, we've been working with, after survivorship of cancers, we have been, a lot of psychological support is needed for these patients and follow-up. We've been working with various psychologists who are part of our group to do that. And as well as we are working during the course of the therapy, we've been giving them subsidized or free housing for them to stay, and also tie up with various organizations. So during a bone marrow transplant, to prevent the kids from falling back in schooling, we've also tied up with a lot of schools to help them with the to keep up pace with the schooling as well. So it has to be a holistic care for all these sections of society. I'm sure there are a lot of things which we have not been able to cover, but within whatever we have been able to do, we have been able to do in large scale, and we've been able to do that well. The last part of the question, which Dr. Gyani had asked, how would we be able to do that well? It all works on the economies of scale, especially for the very high-end work, and it leads to a very highly efficient way of screening preoperatively before they actually come in, preparing the child or the adult for a procedure, and having an excellent team which follows a very strict clinical pathway for them to be able to go through that and work on that. And the only one thing we do, because we do large numbers, even if there are few patients who have outliers and need a large, a long stay within the hospital, we are able to cover for that as well and not charge them for anything else within this one. It all works with that. It doesn't happen overnight, but I'm sure with the clinical pathways being standardized across the, all hospitals have the proper clinical pathways. It is a doable thing for every hospital in the network to do these kinds of procedures as well. Thank you.
Thank you. So I think what he mentioned was that one is the volume. They work on the volume. Number two, I think that is one component I can suppose. And what he mentioned was the efficiency. That means they have designed the workflow in a hospital like, any engineering company like automobile. Actually, that is where the hospitals now have to learn, because there is going to be pressure on the affordability or sustainability. So I think we have to apply all the tools like lean healthcare and volume and, of course, workflow and empowerment of the staff to really make it work. Otherwise, I think the way things are going on, the financial sustainability is going to be definitely an issue. Thank you very much. And now let me turn to Upasana, because what we know about Upasana is that she was the first fellow of the ISQA in the country. So that is a big honor for her. And that means she has been one of the very passionate person in terms of quality. So let me put the question only on the quality, that universal health coverage. The government keeps talking of three things: availability, accessibility, and affordability. I don't know, they conveniently forget the acceptability or quality. So I want to ask you this question, that what Dr. Rupert also mentioned, that how financially, how efficient you want to be. That many people say that with the kind of money available from the government scheme, the quality is going to take the back seat, because hospital will be applying shortcuts, which is very dangerous in my opinion. And you also should be the person who can appreciate this point. So you please tell me, with the present circumstances, how you still maintain quality, and what your message is to other hospitals to stick to the quality practices and patient safety. Upasana.
Thank you, Gyani sir. I have started this journey many years back, and still I believe that quality pays you even after some time. When you spend on quality, you feel like that you are spending a lot and all. But in terms of patient outcome and your length of stay, you are getting it back. So Yashoda is known for affordable healthcare, and as you know, we are always with the government and we are trying to help them as much as possible for us. Even we have adopted 5,100 patients because government wanted to make it TB free India. So we have adopted those patients. Same time, we are on panel of all these government scheme. So what I feel that now government is also very much aware, especially I can talk about my Uttar Pradesh government. They are working very hard to improve quality of healthcare. They have actually hired few agencies, as well as they are doing tie-up with Harvard Medical School, and they are committed to provide quality healthcare. But same time, actually, lots of things are there which we are supposed to, keep in all the time, keep in touch with the government to tell them where we are lacking. What is happening if a small hospital who is doing Ayushman Bharat or something like that kind of policies or yojana, they are having less expenses. When we talk about super specialty or tertiary care or quaternary care hospital, we have many expenses which we cannot cut down to maintain our quality. But same time, as my colleague Rupert said, that if we work on numbers, bulk, then you can survive. But same time, like Yashoda is not. We are making a new hospital, 1,200 bedded hospital, and our motive is to provide cutting edge technology, high end healthcare with affordable price. And now question is how we will do it. So I will do it, and because we are doing it right now also. Everyone is, I am not talking about even these government, whatever they are doing some schemes. I am talking about even private patient. There are many private patients who are not having any kind of this insurance, and they are just paying from the pocket. So it is actually very much required in the hospitals also that we need to just see our expenses, what we are spending on some procedure. What is happening these days, everybody is just according to other hospitals rate list, but we are not doing that. We are just working on our expenses. Then we are keeping only very less profit so that we can pay our doctors, our nurses. But same time, government should understand that now we are paying very high amount of salaries to these workers, because they are also, they also want to get good salaries. So my idea to provide good healthcare is this, that we need to, always keep an eye on our expenses, as well as if, some patient who came to a hospital for some or other disease, and if he will get some different kind of infection and his stay is going long, that is going to be a pain if you are treating a patient on some government scheme, that you will get only that much of money and you are supposed to treat that patient. And if that patient is a private patient, then he is going to say that this hospital is very expensive. So in all these manners, quality is playing a major role, because you are doing everything right. You are not, there is a patient identification, so you will hardly do any mistake to provide patient right care, right patient, right time, everything. Same time, patient is not having any kind of, hospital acquired infection. So for everything, if it's a government scheme or it's a private patient or it's an insurance patient, for everything, if you are doing something which is your healthcare is always with quality. So, and what is the most important thing, that is your patient's feedback about you. If your patient is happy and satisfied, he is talking good about you, so you are already getting back in form of your image, because hospital is facing lots of problem in terms of image. There is no faith between doctor and patient and hospital and patient. Everybody is talking very negative about doctors and hospitals. So we need to change that also, and we can achieve this with the quality healthcare. So I think if we will provide quality healthcare with affordable prices, then your patient will be yours. And with the help of AHPI, we can go and tell government also ki kindly see your expenses also in your hospitals, in government hospitals. You are also spending a lot, so we need to get some at least reasonable amount for some procedures. That is my submission. Thank you, Dr.
Thank
Gyani.
you. So I could understand that without you using the word, you are using the cost of poor quality model. That means, trying to avoid the all wastages, keeping eye on the expenses. And so something very similar model of what we use in cost of quality. So that's good. Now let me turn to Dr. Geethika. I have visited their campus, very huge campus. I didn't believe that I am going to a place which is such a large, educational. It is something like a city, and they are serving the rural population to the great extent. So I think that question is in my frame of mind is that government keeps talking to us as an association that please encourage your private hospital to set up tertiary care hospital in tier 3 towns. So I think let us see, working from that region in Gujarat, how you think we can extend the tertiary care in tier 2 and more importantly tier 3 towns. What is your suggestion which we as an association can pass it on to the government? Dr. Geethika.
Yes, right, Dr. Gyani. So that's a very relevant question. So before coming to the question, I would like to share a little about what I understand about universal health coverage, because that is related to what I suggest as a whole. So basically, as you very correctly told about the components of universal health coverage. So it is equally important to understand that to attain a universal health coverage, what will be the crucial components to go there. What I believe is that there are three main core things which we need to implement the universal health coverage in India as such. So first is a very strong health financing model that needs to be implemented through a very robust governance, and we need to make sure that the hospitals and the healthcare organizations who are going to deliver are sustainable to an extent so that they are delivering the services to a decent quality mark. So financial model, then governance and service delivery. So these are the three core things which itself imbibe a lot of things in them to make sure that we are able to reach to a universal health coverage. Now, as we understand, the definition itself says that it has to be, everybody everywhere can get a decent quality healthcare without any financial hardships. So what is my submission here is, if we make a 1200 bedded in a tier 1 city like Ahmedabad, and somebody has to travel 10 hours from a village to go and access that services, it's not universal health coverage because it's not everywhere, right? So this everywhere word itself imbibes so many things in it that we need to understand that this will require strengthening of health infrastructure at all the cadres and all the levels. Then it includes the healthcare infrastructure at tier 1 cities to the healthcare infrastructure at a sub-center level, which we are now calling as community health centers or urban health centers. So basically strengthening the infrastructure for giving requisite health services at all the levels is the only thing which will make universal health coverage possible. This is not something which is impossible, but definitely in a wildly populous country like India, it will definitely take time. The beginning, I can say, has happened through this PMJY. The model of PMJY is very strong. There is no doubt about it. The vision itself is good. But the only issue is right now that at the grassroots level, the implementation, there are hundreds of problems being faced by the hospitals, as Dr. Neeraj was mentioning. So if I talk about our hospital, coming to the statistics a little, Dr. Gyani, as you were mentioning that PMJY envisions to give services to 50 crore families in the next few years. But the current statistics show that only 25% have been availing these services, which comes to 10 CR. Now this 10 CR accounts to less than 10% of the population as such. So what we can introspect out of this is, with less than 10% of the population getting the services, and so many issues have arose that the private hospitals are now approaching to a point that they are going to deny that we will no more be able to give services under PMJY. Right now, the threshold has reached to that level. So if we want to give services to 40% of the population, we definitely need to make the system much, much more robust. So a couple of point-wise things which are the issues and the concerns right now in PMJY, because our hospital is a tertiary care hospital in Vadodara, and our hospital is like 40% of the people of the patients are PMJY patients. The first important thing here is that PMJY is very selective, in the sense right now it is for the surgical services more, I can say. When it comes to the basic things like medical management, the ICU level care, the critical care, there are no private empanelments. In the city, if we see, all the super specialty hospitals, all the private hospitals get empaneled only for those services in which they feel they will be sustainable and they will not be at a losing end. So this again is a violation of the universal health coverage itself, because it's very selective. So if I feel that I can give services through my CABG and PTCA surgeries, I will empanel for that. But when it comes to medical management of a cardiac patient, I am not doing it, because I know that in 4,500 per day package, I cannot give ICU care as a private hospital. So the financing packages, the healthcare packages which have been brought into PMJY have been a little, I can say, not with a background and a grassroots level search. They are not based on the actual expenses. You just imagine 4,500 a day for an ICU stay. If we talk about ICU, and higher antibiotic, one antibiotic will cost 4,500 a day. The colistin, which is usually given to most of the patients these days in ICUs as a higher antibiotic, that costs 4,500. And now you have to deal with the patient altogether, including everything in 4,500. So this is the this is the height of irrationality in the packages, and that is what makes hospitals getting selective. So what is required is that the PMJY scheme as such, it considers everybody's perspective. We need to analyze the finances. We need to analyze that what is the cost involved in the management of a particular disease in a particular hospital. We may stratify hospitals. There is no harm in doing that. One hospital might be spending 10,000, one might be spending 20,000, one might be spending 30,000 per patient. Their stratification is not at all. So this is one major concern. If I give another example, we talk about the commonest surgery we do in a tertiary care hospital is exploratory laparotomy, and that is usually done in emergency cases. So the package which has been defined for that is 10,000 rupees. Now 10,000 rupees, including the stay of a patient for 7 to 8 days, because exploratory laparotomy is always open. Most of the time it's open and requires the ICU stay. And the package defined is 10,000 rupees. None of the hospitals is doing this surgery, and they just ping pong the patients here and there because it's not affordable for them. It's not sustainable for the hospital to do these cases. They cannot manage and maintain their finances by doing this. So there are endless such examples which are there, which need to be sorted out at the earliest to make sure that the public-private partnership works. Otherwise, there'll come a level in which all the private hospitals will form a group and they will deny giving services to the PMJY beneficiaries. The second concern is a proper referral mechanism. So what I feel is there are a lot of primary health centers, smaller centers, district hospitals from which the referrals are coming. Every night, almost our hospital faces an issue. The patients just come and we have to, there is no space in the ICU. The patient goes to another hospital. There is no space in the ICU. The patient goes to a third hospital and we don't have now time to handle the emergency. So, if we can form something like clusters with big hospitals, like one district, two district under, say, one big hospital like ours, which is a 1,000-bedded hospital, and the referral mechanism can be established in a sense, it is properly communicated and coordinated with the cluster head that the patient is being referred, the utmost efficient management can be done. The patient just keep getting, like we saw in COVID, right? COVID was a characteristic example of an inappropriate referral mechanism in our country. So if we can have proper referral mechanism through smaller centers to a regional level center, then it can be much, much better. It's not necessary that all the patients need to go to a government hospital. We all are PMJY entitled and empaneled hospitals. So such way the bigger hospitals can be the parent hospitals for the smaller centers. The third major concern is in non-inclusion of the outpatient care. Now we all know that all the health insurance just gives services to the inpatient hospitalizations and doesn't give care to outpatients. So basically, if we are going towards universal health coverage, then at some moment of time, some coverage to the outpatient care has to be considered. Otherwise, that attainment will never be possible. Because now what we see is, in case of the rising non-communicable diseases, what happens is the patients who are not taking their regular medications of diabetes, hypertension, renal diseases, they end up coming and getting hospitalized because of the non-compliance, because of inappropriate funds to take these medicines. Most of them are not close to a primary health center. They cannot afford their daily wage loss to go to a health center every week and get those medicines. Sometimes the medicines are not available in the primary health centers, and that leads to non-compliance. At least in the non-communicable diseases, where the patients are required to take frequent and lifelong medications, some component of outpatient care, it has to be included to attain that 100% universal health coverage. We all know that the states, which have been spending more, which have a robust governance mechanism like Kerala into health, they have been doing much, much better in all the indicators. So I guess all the states need to have their own models of governance to make sure that the hospitals are sustainable enough to give the service delivery with a sustainable cost, affordable cost, and a decent quality. So these are some of my suggestions.
Really, I think you have covered, the problem which are on the ground. I think you are speaking from the experience which you are being the trustee. I thought you will not be aware about the ground reality, but I think you are keeping eye on everything. Good. And the cluster approach, I think, is a good model, good suggestion. The spoke and hub model also, we keep talking, but I think this has to be formalized if it has to really work on it. So really is a good suggestion. We'll make it a point in our report on the issue. So now let me go to the second round, and second round again start with the Neeraj Lal. So because you are now in Apollo, and Apollo I consider as the initiator of the corporate or kind of healthcare in the country was initiated by Apollo, and you also I think are considered to be initiator in the digital health. The teleconsultation or telemedicine was the model started by Apollo way back. So with that background, I think you are the right person to tell us that with the shortage of the manpower, shortage of the beds, how digital technology can be really gainfully exploited in today's circumstances in the practical terms. I want to know from you in the practical term, so make it healthcare accessible and affordable.
Yes, sir. So you're very right. I think COVID has taught all of us how to make use of this technology. Apollo started telemedicine way back, but it was not happening. Less than 5% of the people are making use of this. But now I think Apollo is doing 35% of the consultation through a virtual platform. And somehow government is not making use of this technology in a greater extent. The people are still traveling to a place like what Dr. Geetika was telling. If you got a tier 1 city and everybody is going to tier 1 city, I think we have to divide primary, secondary, and tertiary healthcare, which is a part of board committee. So I think we should use this technology to a greater extent. I was reading one report which is talking about flipped care. So patients today are more conscious, they are tech savvy, and more willing to use technology. As a result, this flipped care has been used. Say, for example, average time a person spent for the year with a clinician is just 5 hours, and they spend rest of the waking hour around 8,755 hours looking for themselves in the term of healthcare. So I think if we use these hours to use this technology in order to go to the patients and make use of the digital technology. I'll give you some examples, sir. Like Apollo Ahmedabad got around 102 ICU beds, but we manage around 1,200 ICU beds in various tier 2 and tier 3 cities. We got a concept known as e-ICU. So through e-ICU, our central workstation is there in the hospital Ahmedabad, and we used to cater all these towns of North Gujarat through e-ICU concept, where our critical care consultant is touched with all these people. Because when you travel to Saurashtra part of bed, there are good ICUs are there, but it is not managed properly because of the expertise. We started a patient transport mechanism. Suppose whenever we book a cab, like whenever we travel in the cities, we use this application of technology. So we have done this technology in the patient transport mechanism. So what we do, whenever you require a patient transport person, an app is given to various customer care executive across the hospital. So whichever the close by patient transport person is there, he or she used to come to the ward or a ICU or a OT and transfer the patient from one area to another area. Apollo 24/7 is one of our major platform, digital platform, and it has been seen 12% of the patient coming on a virtual consultation is not from India, they are from outside, living outside the country. So I think if we use this technology in order to reach the people, and you're talking about acceptance and affordability as well as the reach. Apollo has started using AI cameras, and now most of the doctors, like in Apollo Ahmedabad, I can say 67% of the patients, we are giving e-prescription. Whenever a doctor is talking to the patients, he is spending time with the patient, not in writing the prescription. There is a Ogneto device which automatically print out the prescription. It goes to the pharmacy, a medicine packet is made, and automatically our customer care team do a CPOE, clinician prescription order tracking. So in the term of business, in the term of tracking, we can do. It has been seen in most of the corporate hospital, whenever a doctor advises a procedure or a surgery, say for example, after 15 days or 1 month, sometime the patient also forgot as well as hospital. So we used to keep track of this technology. So Apollo is using this technology, but somehow I feel government is making a big healthcare infrastructure, but without the use. I have never seen you're doing a teleconsultation with one of the government hospital. So I think technology is there, and thanks to the COVID, hospitals are making use of this technology. Hospitals are not meant for small procedure. Home healthcare is a big concept which I think we all have started. I think if the government hospital also attach with the hospitals like corporate hospital, we can use this technology. Sir, 50% of the total Indians use this internet now. With 5G coming, I think we can make use of this technology, and government can make use of this technology in a big way.
Thank you. Good one. Yeah. Now let me come back to Dr. Rupert. So, I will go back to my earlier days in AHPI 2012, 13 and 14. So one of the major projects which we took with the government was equal UG and PG seats. And Dr. Devi was the one person who was leading the whole initiative. In fact, even I was not aware, even government was not aware at that point of time that this is really an issue, that we were only counting the MBBS doctors. But I think Dr. Devi brought this point that, and I remember at the figure that time, 50,000 MBBS seats, and he was telling us 18,000 PG seats. So he said, how can we manage the country? So I think that was a major initiative at that point of time, which made the government conscious. And of course, since then they have been increasing the UG and PG seats, DNP seats. Diploma now has started. So I think all that has started, in that point of time. So I think you are the right person to tell us, how do we fasten this capacity building to have the requisite number of not only doctors, I'll put it an extended question to you also, doctors, nurses, and even the allied healthcare workforce. Without them, you can't really meet the objective. So please educate us. How do we build the capacity in the fastest manner?
I think a lot of work has happened in the last decade or so, like you rightly said, and number of postgraduate seats and the undergraduate seats has, rightly been increased, and a lot of hospitals across the country, whether it's private or the public hospitals, have all participated in this entire training of the next generation of clinicians. In our own network, we have trained more than 10,000 doctors, and at any point of time, we have around 800 doctors in training. We have trained more than 12,000 nurses through our nursing schools, and around 6,000 paramedics. But that set apart from that, as much as those things have to continue, to have an efficient and effective delivery of healthcare workforce is the most crucial part, and it has rightly been recognized as that. And if you see the density of healthcare workforce in the country, it is very low when you compare by global standards. And it is also skewed towards a particular distribution is not proper. You see certain states having very good healthcare workforce, like Kerala, National Capital Region, the Tamil Nadu, Maharashtra. But even within these states, there are certain districts which may not be appropriate. So we have a very uneven distribution of our workforce, and that is very, very crucial to get that right for us to deliver the universal health coverage for all our people who are mainly in the rural area. And another part of the problem is most of our healthcare workers are in the urban, predominantly in the tier 1 cities, and that makes it even more difficult for us because the half of our population lives in the tier 2, 3 and the rural area. And that makes it the very, very big challenge for us. And if you look at the statistics, by 2030, I think we will be still short by around 1.3 million healthcare workers. And that is a huge task for the government and for all of us to get us ready to deliver on the accessibility and of the universal health coverage. I think the most key to this entire thing is the way the current population of ours is moving. Even though we are considered a very young nation, we have more than 200 million people who are more than 65 years of age. And that is a very, very large number. And even those who are in the 40s to 60s, a significant amount of them are having a lot of comorbidities, which makes them very vulnerable for various other non-communicable diseases. And that makes the challenge very, very great for us. So the most important thing, if you look at the Western world, the community health centers are all, the healthcare workers are predominantly from the community, and that is what we are lacking. And that is what the government has to focus on, and we all have to partner with the government to skill and upskill the necessary people and the adequate participation of the community in getting the various skills amongst the community. The Healthcare Skills Sector Council has made a lot of progress in identifying the various areas, which can range from simple things like phlebotomy to lab imaging to non-invasive diagnostics to the very end of the paramedics and the nursing. But I think a lot of work has to go into curriculum, which has to be very, if you look at nursing and direct patient care, it has to be mannequin and simulation based, and then actual patient care area, they've been brought to patient care area. And these are some of the things which needs to be done. If you look at lab medicine technicians, most of the current generation of machines are all fully automated. At best they will be partially automated, but most of the training requires them to be doing a very manual kind of this one, which may not be very relevant. I think we need to skill and upskill the existing force with their very relevant technology, with the relevant things that they need to do. We just did a pilot around a month back. We just took our fresh graduates who came from one of the northern states of our country, and we just experimented with that, and we were able to within a three-week period, from our archive database of ECGs and blood gas machines, we were able to teach them to decipher with all the right interpretations and the treatment for the what needs to be done. And a lot of within 3 weeks, we were able to get them to such a high level of skills that they could directly be going to patient care area in the ICU. So it's all about passion of training, having the right partnership. The need is also what is the actual requirement, because it will vary from different healthcare situations and different healthcare settings to this one. If you look at a quaternary and tertiary care, the requirement for a skill will be different to a secondary level care. I think nursing and paramedics should be based on skill sets. We need to recognize at different levels of skills what it is, so that their employability, the duration of the training, and all these things can be streamlined, and we can get them, and we'll be able to come very close to the 1.3 million, which we think will be the shortage by 2030. But the key to it is the community participation of these people to come within to get themselves skilled for various healthcare programs, and the infrastructure to also go deep into the tier 2 and tier 3, so that they will find adequate employment and in their own community, based setting, so that it will be making a very major change for the society, and delivery will happen not necessarily in tier 1 cities, but it will happen at where this is actually required.
Thank you. Great. Now, I think Dr. Geetika mentioned insurance in her previous talk, but now I want to specifically ask you, because the hospitals keep on complaining the insurance are functioning these days. So I think we want to understand from you, because as I can see, you have experience right on the ground, how actually the insurance company can work together with the private sector to make healthcare accessible and affordable, because there are still large issues in terms of insurance, because even insurance companies are complaining that even the kind of budget which they are operating is not enough, with the cost increasing, and they keep on trying to compare that if the hospital can manage within the PMJY rates, why can't they also work with a private insurance? Though we keep telling them that this is a cross subsidy model, that is a social aspect which we are obliged to do, and the other through private insurance we will have to get some cross subsidy. So I think this is a complex issue. I think you are the right person to tell us, educate us, how insurance company or insurance sector can be aligned with the private sector to achieve the objectives.
Yes, yes, Dr. Gyani. So I think we are approaching the timeline, so I'll cut it short. So PMJY has set the standards, as you were very correctly telling. So all the insurance company have an eye. So if the hospital can treat in these rates, then why we shall not cut the rates as well. So that's very correct. So basically, I believe that there are 3 or 4 models for insurance in our country. One is the government-funded PMJY scheme, which is transformed gradually from RSBY, and then merging different state-level schemes, like we had Mukhyamantri Amrutam Yojana in Gujarat. It is now merged with RSBY. So this is the largest insurance model in the country at present. Then we have some social health insurance schemes, which we call SHIs, which include like ESIS, CGHS. These are the social health insurance scheme. And then we have the private health insurance firms, which are very fragmented, divided into different segments, different geographical areas, different modus operandi. So these are the 3 basic segments. What I feel about social health insurance schemes, they are in a very shabby state at present. There are no proper guidelines, no proper SOPs in place, and ESI beneficiaries are facing great troubles into accessing quality health services. So this is already in plan, merger with the Universal Health Scheme, which is the PMJY. The merger of social health insurance scheme is already in plan. It's going to happen over a few months only, I guess. The private health insurance schemes, as we know that there are a lot of concerns, because of which the statistics say that today, if we take into account the people who are availing and who are getting services through health insurance companies, is just 20 to 25%. And if we go broader into the people who have an annual income of less than 5 lakh, it drops to even further 15% of people who have less than 5 lakh annual income. Only 15% of those people are availing services through health insurance. There must be some concerns which have led to these statistics, and the remaining 60 to 70% of the people are spending out of pocket expenditure for availing the healthcare services. Now, if we come to concerns why more people are not availing the services, I feel one is the lack of transparency, in the sense they mainly work on risk susceptibility model. You are at a higher risk of a particular disease, more premium to be paid, no coverage of pre-existing illnesses, a lot of issues in settling of claims, lot of issues arising in the documentation part. One is that, and second is lack of awareness in tier 2 and tier 3 cities about health insurance. People still don't consider them as a transparent and and a robust system, so that they get ready to pay the premiums which are charged by the health insurance company. What I see as a solution to this is the institutionalization of a universal health insurance thing, which is very well been implemented in many countries like France, which is one of the best healthcare delivery system, has a universal health insurance scheme under which 77% of the money is funded by the central government, and the entire money is managed from the taxes of the people only. So the mechanism is such that it is governed through a single card system, a single health card, and they are as an example of a healthcare delivery system for the entire world, I can say. So a universal health insurance system with proper stratification, like the bottom line can be PMJY, in which the people are not paying. It is the premium by the state government and central government on a sharing basis. There can be bronze cards, there can be silver cards, there can be gold cards on the basis of the paying capacity of the people and the sharing of the premiums by the people and the government. And then, it can be for a little time, it can be supported by the private health insurance companies, but eventually we very well need, in a contextual form, a universal health insurance merged into a single system, so that the costs which are very well worked out with the background research at a standard level, and the stratification into gold, silver, bronze will it will make possible for the different cadres of the hospital to charge as such to these level of patients. And this can be very well done. Somebody who just want to empanel itself for the gold card, that has to be the flexibility. For example, somebody like Apollo spending hugely in infrastructure, they must have the flexibility of treating only the gold patients to sustain their infrastructure, to sustain their recurring expenses. Hospitals like us, whose vision is to give affordable care, whose vision is to treat low socioeconomic strata people, because we do have some other level of and some other source of revenue for us. So there are hospitals which do have alternate sources of revenue. And there are hospitals who are completely relying on the revenue out of patients. So this difference between these hospitals has to be considered, and the flexibility for choosing their own model has to be there. Everybody cannot be put in the same bucket. That is how it is, because everybody's revenue model is different. So this is what is my suggestion.
Good.
On insurance.
I think we will put you in the task force for the insurance to solve this major issue. No, good one. Universal, health insurance is a good suggestion. Now let Upasana have the last word. COVID, whatever you say, I think one big positive came from the COVID, that it was the major wake-up call for all of us in the globe. So I want to ask you, I think you are also in the thick and thin of COVID era. What really have we learned, and what private and government sector can do to, face this kind of eventuality in the future?
Thank you. As you asked me that what we have learned, I think everybody has learned, whole world has learned that life is one, we need to live it fully, as well as we are supposed to look after our health. Because before this COVID, no one was interested to go for health checkup or think about their heart problem or something like that. But now you can see that after COVID, lots of people are having this heart problem, especially young generation, or who are actually fit people who are getting heart attacks in gym and all. So this is a wake-up call for everybody that you need to take care of your health. And I just wanted to say one thing which Parul was talking about, that hospital has to be, there are different hospitals. I also want to say this thing because this forum is Voice of Healthcare. So I really want to just urge this thing, that this through NABH or some other body like AHPI, hospital has to get some kind of, category wise A plus, B plus, A, B, C, D category. We should get some category. So, and according to that category, rate should be decided by the insurance company and by the government. Same time, I wish that AHPI should take initiative again, because you have already taken this initiative. We should sit with the government, and from government side, somebody who is managing hospital has to be there to again redo everything and get some reasonable prices. So everything should be win-win situation for hospital as well as the government. Only then, if there is again situation of COVID or some other disease has to come, and we healthcare worker has to be there. So I want some extra benefit for healthcare worker has to be announced by the government. Why we should choose healthcare? Why a person has to start a hospital? Why a person has to become a doctor? Why somebody needs to become a nurse or some paramedic? There has to be some incentive for them. Not only all the time, criticism, or all the time that, if patient is getting discharged from the hospital and perfectly fine, then he is saying, I am paying for that. What is big deal in it? And if he is not, some problem is there, or he cannot survive, then people are actually doing violence with the doctors or in hospitals. So there has to be something, some law has to be there. As I have seen that the Supreme Court has taken some initiative that if there is a violence against doctors, then a FIR has to be lodged within 1 hour. So, now healthcare needs something from government side to encourage their self. Like why I am going to start one more hospital, why anybody should become a doctor. So, and there has to be some good amount of money for private healthcare, and same time private healthcare has to be there for PPP model. With every CSC or PSC, one private hospital become partner. So whatever services are not provided by government, we can provide them. But there has to be some, difference between hospital, between two hospitals. Somebody is actually spending a lot, like big hospitals, Apollo and all. So we cannot compare a small nursing home with a big hospital. So there has to be some mechanism to resolve all these issues. And after this corona, everybody understands value of healthcare workers and value of a doctor and value of their own life. So everybody has got a call from the God that kindly wake up and take care of your health. So it's high time to, provide best facility to the hospitals as well as healthcare workers. So I think AHPI can take a lead in that. And we all are with you, Dr. Gyani. Whenever you want, we will be there to help you. Yeah, thank you.
Thank you. Very nicely summed up. So as I can put it in 1 or 2 minutes, that COVID naturally was a wake-up call, and healthcare should now become the central stage as far as government is concerned. And I can see it is happening already, that 2 schemes, as I mentioned to you, Ayushman Bharat and National Digital Health Mission, they are working on this one. And but the building hospital takes about 3 years time, in greenfield, hospital. So till that time, I think area. So I think with that thing, we should be able to overcome this deficiency in our present system. And for that, I think our strong recommendation should be that government must incentivize the private sector, because the resources with the government are limited. And if they want private sector to invest, there must be some kind of incentivization. Then, of course, the private sector is ready. I think all 4 of you have mentioned this one, that they are ready to come up and work with the government to overcome, the issues related to. And I suppose that Voice of Healthcare has got enough inputs from the 4 experts and the Universal Health Summit 2022. So thank you once again, all my panelists, and hopefully we'll meet again. Thank you.
Thank you.
Thank you, sir, and thank you, Voice of Healthcare. Thank you, everybody.
Thank you.
Thank you.
Have a great day.